Hi, everybody. Good morning here. Well, good late morning here on the East Coast. Good early mornings, those on the West Coast. How are you, Dr. Ketting?
I'm doing well.
Ready for you get to kick off our
Oh, I
ocular
do. I'm
emergency
in charge
summit.
of the slides today.
Yes, you are. So, well, I will get started. I know we have a long day today and tomorrow, so there's a lot of CE to get through, but welcome everybody to the Ocular Emergencies Summit, which is today and tomorrow. So I hope you're here for all of it. I'm your host, Dr. Jennifer Stewart. And some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. This is a 2-hour course, so you need to be here for an hour and 40 minutes. So for a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with your OE tracker numbers. We'll also display that QR code at the end. CE certificates will be emailed within 4 weeks. And I know this is a long presentation, so make sure you ask questions using the Zoom on-screen floating panels. You can use chat and Q&A. Feel free to put those questions in as we go through. Don't feel you have to wait till the end so you don't forget them. We probably won't address them as we go through, but we'll leave plenty of time at the end for Q&A. And here's where you can find those if you're on your phone. So I get to once again introduce Dr. Cecilia Ketting. She practices at the University of Colorado School of Medicine in the Department of Ophthalmology in Denver, Colorado. Her primary focus is in anterior segment and ocular surface disease, neurooptometry, and perioperative care. She partakes in clinical research and has served as externship director and adjunct faculty for several schools and colleges of optometry. She's a member of Intrepid, a fellow in the American Academy of Optometry, a diplomate of the American Board of Optometry, an active member of the AOA, and has served as both local and state officers within the AOA. She was named Young Optometrist of the Year by the state of Virginia. She lectures locally, nationally, internationally, and on WooU at conferences, continually contributes articles to, and serves on editorial boards for multiple publications. Welcome again, Dr. Ketting. Thank you for being here to kick off our Ocular Emergencies Summit.
Absolutely. I'm really excited. As Jen mentioned, please, this is a long lecture for you and me, right? We're going almost 2 hours here. So if you have questions, I like to answer in the moment if we can. So please don't hesitate to put it in the chat. I've got it off to the side so I can see it, and I'll do the best that I can to answer any questions. Just for the sake, I'll have this slide up too, but financial disclosures have all been mitigated. Honestly, we're here to talk about some emergency type stuff, so we're really not getting into anything where that's applicable. So this is fun. I'm excited. Stephanie asked me to put this together for this weekend, and I was really excited. I always love talking about emergencies. I know a lot of you know I do a lot of ocular surface and cornea, but I also see emergencies. Guess what? We all do, right? And so I will tell you, I will take an entire day of emergencies sometimes over some of my dry eye patients, just because it's interesting, right? It's a varied experience for us. And so that's kind of what this is. We've got a smorgasbord of cornea meltdowns down to retinal blowouts. And we're just going to kind of walk through some of these interesting cases that I've had. And that's how we learn and how we figure out what to do in these cases is kind of sometimes by either picking each other's brains or by coming to some of these lectures and seeing it and then having something random come in our office and go, oh, I remember something like that. So we as an optometry have to be aware, and not just optometry, it's all medicine, honestly. Let's talk about smartphones, online exams. We've got the advent of our AI that's coming in that will be helping with some of this telehealth that we do. And telemedicine has become a big thing, especially we talked a little bit about this. I actually developed a part of a version of this lecture pre 2020, right? And the discussion of telemedicine and smartphones, that all of this was kind of like and then 2020 hit and it all blew up. And now since we've moved back to full in clinic and there's less of it, there's still a lot of aspects of healthcare that still are using a lot of online or telemedicine exams. I know my husband, for his primary care doctor, he has to see them every 3 months and he does it online. He doesn't go in. And we all get the lovely questions from our patients that say, do I have to come in? Can't we just do an online exam or can't you just call me and do a telemedicine? And it's really fun to have to tell them that, no, I can't actually see your eye in any kind of level of detail to accurately decide what's going on. Now, that's probably going to change in the next 5 years, honestly. Look at the quality of pictures that are coming out of our phone and the videos and I use my phone to take pictures for clinic. So it's going to continuously change. And so this iteration of the lecture is focusing more primarily on what are we going to be doing in clinic, but I think it's good to give pause and think about those things. And then as so much as what am I going to talk about what is considered more immediate or emergency, urgent, semi-urgent, and routine, this is more of my definition. And just so kind of you have reference as we're talking through this. And those patients, that are more immediate or emergency, those who are, I'm saying, need to come into the office immediately or to the nearest emergency eye care facility. Urgent, someone who probably needs to be seen within 24 hours. Semi-urgent, within a week. And routine is someone who's next available or something that doesn't pose an immediate threat or have any kind of present issues where we need to see them immediately. Those are a lot of my, dry eye patients, right? So the other thing is like thinking about how to triage these patients. And this is something that we need to, and I talk a lot with para-optometrics about is our staff, right? And how to triage these patients and having a written protocol for our staff to understand, just like what I was saying, is what's considered routine, urgent, or emergent, so that they have a good way to be able to break this down while they're on the phone, better triage it, and figure out who needs to come in. So our clinic and our flow and our chairs don't get too overwhelmed with things that really probably could have waited till next week to be seen. But I do still have that gut, I do use some of the gut feeling sometimes where it's like something sounds funky about that. If a patient sends me a message through our system and I say, just come on in, let's take a peek. The big one, we'll talk about this, is subconch heme, right? A patient calls in and says, my eye is bleeding, right? And you sit there and go, okay, is the eye really bleeding or is it just a subconch heme? Those are the ones where pictures are actually really helpful. So the way that I kind of break this down, I grew up in the Midwest. Apparently, I've talked about the 5 Ws other places. 5 Ws was not something that was learned everywhere. Midwest, yes, I tend to find people who grew up in the Midwest did know what this is. But it was how we were told to look at articles, look at news and things like that. And it's the who, what, when, where, and why. And then you can add on to that. But the idea of that is helping to figure out what's going on. And it's just a really quick thing to kind of keep in the back of the mind to say who, what, when, where, and why. And it's great for staff for them to be able to say, okay, let me get these details, and that will help better assess what's going on and triage. Does this need to come in now? Is this more likely something that can come in tomorrow? Is this something that not even needs to come into our office, right? That can go over to the surgeon because that's not even something we need to see today. But so let's get into some cases. We're putting our coat on, we're grabbing our bag, when all of a sudden in walks one of our patients. We've got a patient who's a 74-year-old white male, complains of eye injury to the right eye when walking through the woods, and he stepped on a piece of rebar that flipped up and hit him across the side of his face. This really is a patient of mine. I was in our Suffolk office. I'm only there on Fridays. Came in on a Friday and said, this is what I was doing this morning, and I smacked myself in the face. Says my eye feels gritty, wet. I'm sitting there going, okay, that could be questionable. I can see out of the eye, but it's like looking through broken glass. Lots of floaters. Okay, well, we got our who, what, when, where, and why, right? We got the who, it's our patient, right? The what was got hit in the eye. Our when was that morning, right? So we know it was recent. It's not like he's saying, hey, this happened 6 months ago and now I'm feeling like this, right? That's a little bit more concerning when it's an immediate. And so we've got kind of our ideas here. We've got what's going on. So let's see what the findings. We said, yes, come in immediately. Let's see how you're doing. Vision 2020. Whew, okay. It escalates down a little bit, right? I know that this patient has had cataract surgery. So looking at the vision, we're going to talk about the position of the IOL in a second, but vision is a good indicator of what else might be going on too. Pressure's another one, right? But we did it after slit lamp exam because I wanted to make sure we didn't have any kind of penetrating globe um, issue. So we knew we were safe to check pressure after looking through slit lamp. Pressures are good. We don't potentially have something where we've got fluid exiting the eye. We don't have a potential penetrating issue where we're having a deflation of the eyeball, which happens. I've seen a few of those. Okay, slit lamp exam of the right eye because that's the one that got hit. The left eye is completely unremarkable. Eyelids, we've got bruising and 2 plus edema that's starting to happen. Subconch heme superior with a 12 by 2.2 to 3 millimeter superficial laceration under the eyelid, not involving sclera, right? Not negative Seidel. Cornea is normal. Yay, another win. AC, dark and quiet, right? And we can talk about that in a little bit about what happens with the AC later. PCIOL, good. In position, it's not moving. I don't see it's dislocated. We're going to eventually dilate him because I got to look at everything else, but I need to check this part first, right? Posterior, few floaters, zero point 0.3, no holes, tears, retinal detachments, right? So good. Okay. Now, what we did find was we've got this gorgeous conjunctival laceration. So you can see we got some photos here. Again, I use my cell phone. This is all that I'm using, but when we see these, you potentially wouldn't have seen it if you didn't lift the lid. It is tucked under that eyelid because you see that it's above the limbus here. So make sure, especially if somebody's coming in for some kind of trauma, we want to make sure we're having them look down, lift the lid, look under, right? And when you see a subconch heme, especially in somebody who's sustained trauma, you want to make sure that you're taking like a little Q-tip and you're teasing around the area because you need to look to make sure, is there, like we see here, a little laceration? How deep is it, right? Are we penetrating? The other thing that you need to do is you need to see, is there anything trapped in there, right? So with this patient, what we did was I went ahead and consulted my cornea specialist because the question was, okay, do we leave the wound open? Do we close it? And that could be done with either putting, usually it's just glue, or you can do sutures. It's not deep enough that I thought we needed sutures, but I did consult my cornea specialist, said, hey, this is what I'm seeing. I think we're probably okay, but I'm debating on if I need to close it. He said, let's hold on, let's leave it. Bandage contact lens. We did a contour, so not just a regular contact lens. We needed a much larger diameter contact lens so it would sit over it because otherwise it would potentially just be rubbing right into that conjunctival lesion. So we put a nice size contour lens over, antibiotic 4 times a day, and then we were going to follow up on Monday. And at that point, we did start steroids at that point and decided against closure for sure. Now, honestly, at Monday, we saw him Friday. We're not going to do a closure anyway because it's been open for too long. We knew honestly that if we're making the decision on day one within hours to not close it, very similar to sutures, right? You aren't going to close it later, more than likely. So with any ocular trauma, this guy or others, right? We need to evaluate the eyelids. We need to look at the periocular structures first. You see in this kiddo, comes in, dog bites. We've got nice loss, digs here. If I see that I've got stuff like that and I've got actual periocular wounds that probably need sutures, that needs to probably go to the ER first, unless I have an oculoplastics who wants to do those sutures. But sutures have to happen if we've got a laceration around. If those are going to happen, they have to happen generally within 4 to 6 hours is still the kind of the rule of thumb there. So we want to send those off to be dealt with first. And, obviously we're going to make a quick assessment of the eye just to make sure we're okay, but that's going to probably need to be dealt with. The only time I would argue that's not the first thing to be dealt with is if we have an open globe, right? And if we have an open globe, we know that there's a much larger risk for not only infections, potential damage to the eye, loss of vision, potentially loss of the eye itself. Um, but so if we see nothing on the outside, we start to look at the ocular surface, looking for subconjunctival hemorrhages, just like I said with my patient. If we see that, we want to check for a laceration. We want to rule out that there's not any open globe, put a little bit of fluorescein on there, painting it to make sure to see if we see any fluid that's coming out. Trick on that too is you can put the fluorescein over the area where you have the laceration. You can then also push on the eye just a little bit near the area with a Q-tip to see if anything, you get any kind of regurgitation or fluid coming out in that area, because it will self-seal most of the time is if it's a small laceration. But we want to rule out the open globe because that's obviously a much higher risk. Looking for scleral rupture from any blunt trauma near the limbus. Posterior to muscle insertion, that's actually the most common area where we can get some scleral rupture. So you do want to make sure that you're looking in that area. So there is a question that popped up. Would you start this patient on an oral antibiotic to avoid infection, depending on when they make it to the ER? That's a good question. Honestly, if we are it depends. My patient, I wouldn't have obviously started, but if we're looking at this little guy here and we're sending him to the ER, they're going to get there within 4 hours. If it's going to be more than 4 hours before they get to the ER, depending on where you live, it may be more rural, it may take longer to get there. Um, it may not be a bad idea just to prophylactically, but I think that would be a very situational type thing. So now this is another trauma. So remember, we're looking for anything anterior chamber. We're looking for any damages there because anytime we have blunt trauma, that not only can affect the external portion of the eye, but it can cause iris break in the iris, essentially like a dissension. You can get your hyphema that we're seeing here. This is a really nice, cool coagulated one. Obviously, it's probably not going to look like this on day one when you're seeing it. This may be later on, but we're looking for any kind of signs of hyphema. With any issue as far as inflammation, so I said with my patient, he had a dark and quiet anterior chamber, and he did, but remember with trauma and traumatic iritis, typically it will take about 48 to 72 hours, and you may still see some traumatic iritis from something. So I'm obviously going to be watching this patient closely anyway. We saw him Friday, we saw him Monday. Monday, still no signs of traumatic iritis, so we were probably out of the woods at that point. But I still educate the patient. And then what about this? This is a good old one. This one I will give my credit to Walt Whitley because he actually had to deal with this patient, but it was a patient of ours who, remember when I said I was a little concerned when this patient came in and said that they were having watering. That can be a sign of somebody who has a penetrating globe, such as this patient who fell in the middle of the night. She hit her head on the bedpost and then felt water coming down her face. And well, unfortunately, because she has a corneal transplant, she did dehiss the corneal transplant and now has an open globe. This is one of those emergency type patients. And this is why sometimes when we hear somebody say something, it could turn out to not be an emergency, or watery eye could turn out to be an emergency. And then of course we can get these patients. You know, I hit my eye and I actually have blood coming out of my eye. And, we probably want to check on those patients. So, conjunctival laceration specifically, honestly, this is corneal as well. Identifying using sodium fluorescein or a drop to highlight any area of the abrasion as well. But it also helps to check Seidel sign. But putting a little bit of fluorescein in there if you don't have a fluorescein strips work a little better because it's a little bit more diluted. It's not as thick and heavy. So I like those better, but if you don't have that, you happen to have fluoresce or whatever in the office, put it in, let it sit for a minute, and then go look through for any signs of an abrasion, and that'll kind of help you figure out where to look, right? And then taking that cotton tip applicator, as I mentioned, to kind of look for any residual foreign matter. So you want to kind of tease the tissue to see if you can see anything embedded. And then you also want to do that so that you can kind of identify whether or not if there's any more deep tissue involvement, as we were talking about before. Deep or non-mobile foreign body, or if uveal tissue is showing, those are ones where you're going to want to refer out. I don't think I have that picture in here, but I had a patient with a really interesting little piece of um, what we figured was kind of some kind of vegetative matter. We aren't really sure what it was, but it was actually under the conjunctiva. It was buried between the conjunctiva and the sclera. And so that one I actually had to refer over to, and depending on state, right? At this point in my state now, and the laws where I was before, we probably could remove it, do a small incision and take it out. But honestly, like, do I want to take the risk? Do I want to deal with that? No, probably not. I'm just going to send it to my cornea specialist. And then definitely doing a dilated fundus exam. Apparently, I forgot to put my X in there. So an exam for any ocular trauma, because we need to, just like we saw that hyphema patient, one we're looking at the anterior, but we got to remember the posterior as well, looking for any damage there. Coupe, contracoupe can cause swelling. It can cause all sorts of things going on in the back. So we just want to look at that. Also, want to make sure we avoid dilation if we do see uveal tissue that's prolapsed in a wound or a foreign body in the anterior chamber, which usually indicates that something has penetrated and made its way in, or if there's a disorganization of the globe. Those things can indicate bigger issues, and if you dilate, you may actually worsen them. So we want to hold off on that. Now, what do we do for a small laceration? Typically an antibiotic ointment or drop 4 times a day until defect is closed. Want to avoid rubbing, discontinue contact lens. It depending, right? If it's a small laceration on the cornea, you may elect, like I did in this patient, to put a bandage contact lens just to decrease the mechanical rubbing of the lids on the laceration. If it's a moderate or a large laceration, consider referral. May require surgical repair, cauterization, absorbable sutures, or glue, and then they're going to obviously need to sterilize the wound. Now, the other thing I will say with this is thinking about location of the laceration. This worked out well in this patient to not do a suture because it was horizontal and it was under the lid. So there was a little bit more protection. If it was vertical, that would be more concerning. There tends to be more pulling with something that's vertical versus horizontal. There's less pulling on the tissue. Something vertical is probably not going to close as well on its own and needs to have some kind of closure, whether that's suture or cauterization or glue. If it's vertical, there's more likely going to be that need because you're going to have that just natural pulling on the tissue, not letting it heal properly. Okay, let's move on to another fun case early Saturday morning. We're going to talk about our patient who's a 22-year-old female. Slept in my contacts last few nights and I woke up in pain and the light hurts my eyes. Cool, good job. Yeah, we've all had these. And so what should we ask? At this point, we need to know, okay, great. You slept in your contact. We already know this happened last few nights, woke up today, I'm assuming, but we want to ask, okay, is this today that you woke up? Has this been a few days? How old is the contact? How often are you throwing them away? Do you ever take them out and clean them? What are you using to clean? Double check that, especially there's not anything that's been on a recall list of the patient's been using. Are you putting any drops in your eyes? Do you swim with your contact lenses? Have you been in a hot tub? Have you been in anything where we're concerned for any kind of bacteria being introduced to the contact lens? What about yard work? Have you been doing yard work while wearing your contact lenses, right? So we're trying to get an idea of what potential microbes. Now, do you have to ask this before you look at the eye? No, you can absolutely look at the eye and then go, cool, we got an ulcer. Let's figure out which one this is, right? Because we need to figure out how we're going to treat this. So when we know that sleeping in contact lenses is number one, and I will sit up here and say it, guys. I don't care if it says on the contact lens that it is extended wear. Just don't sleep in them. Just don't let your patients sleep in them. We don't want to deal with these things. Yes, we'll have you had patients and have patients been fine before? Sure, absolutely. But it is just not worth the risk when I see these patients coming in. I had a friend of mine, my roommate from college. She's like, well, so I woke up this morning and I'm like, since she's driving down to Florida, this is literally last weekend. She's like, hey, I'm driving down to Florida. I woke up this morning and my eyes are really light sensitive, or one of my eyes is really light sensitive. It's red. And she's like, and I don't want to tell you, but I've been sleeping in my contacts because they're the extended wear, but I take them out every 3 days. So good for her. Good for her. But okay. Nope. She's like, I know I'm not supposed to ever sleep in any contacts. It's like, yes, we've had this conversation, usually over a couple margaritas. Um, so she's like, yeah, I slept in my contacts. And I was like, cool. I think you probably have an ulcer. We walked through, did my best triage I could over the phone, but had her get out of the contact lenses. So it does happen, right? Other things, non-surgical trauma, surgical trauma, lid dysfunction, things where we're getting exposure, right? It's leaving this little window while we're sleeping and or throughout the day where things can get in and also leads to dryness. Ocular surface disease. I see this all the time in patients. We know that when we have dry eye or any part of ocular surface disease, right, when there's desiccation of the epithelial cells, what do we have? We have little openings. We have little openings between the skin cells on the front surface, and we've got an area where bacteria and or fungus can unfortunately get in, make a home, and create a problem. Systemic diseases, topical medications, and usually all of these things are kind of just leading to openings and kind of an opportunity, right? And that's all the bacteria is. It's an opportunistic infection. So what we want to make sure that we're doing, we want to get a good history in these patients. We want to do slit lamp examination, photo documentation is ideal. And part of that is because it's, as best as we can to describe things and measure things. It's really great if we can see a photo. It is much easier to identify it's improving. Also, in a lot of these patients, they're probably going to be monitored every day or every other day to make sure how they're doing. And it may not be you, it may be one of your colleagues who's going to see it, and your description may be great. But a photo, again, is going to make it much easier for continuity of care to make sure, is this actually getting better? And then remember culture rules, 1, 2, 3, if it's within 1 millimeter of the visual axis, ulcers that are we have two or more infiltrates, or if it's 3 millimeters in size or more in diameter. Now, caveat to that, I say all ulcers should be cultured. Really, honestly, let's just do it. It makes it easier. I've had too many of these come back where they aren't responding, and then I have to figure out what the resistance is. And so I just go, if I've already done that, I cut down on the time that it's going to take. It's the way that my practice has been. The nice thing too is with cultures, I think it's gotten easier. You can do so in my clinic now. We do still have all the plates, and I have a microbiology background. I love the plates, they're really fun. But we now have eye tracks, which is a little swab. You swab it, you send it off. It's PCR, so it's going to check for sensitivities. It's going to tell me what types of bacterias, fungus. It's going to get a fungal, as opposed to waiting the 3 weeks to get a fungal growth. It's going to tell me about fungus a little bit sooner. And then it also can tell me about viruses and things like that, which is really cool. But so if we're, looking at it, the big thing we need to figure out is we need to figure out whether or not this patient has fungal, bacterial, or both, right? Because we know that it can happen in both. Other indications for cultures that even if you're not doing the 3-2-1 rule or my rule of just culture everything, because I know it's not realistic. If you've got somebody who's got a hyperacute conjunctivitis, neonatal conjunctivitis, Post-operative infections are really good to make sure that you're checking that because it usually means if they're post-operative, they're already on something. So they're on some, if something pops up, it's probably not just an ulcer, right? We're talking about a conjunctivitis or any kind of infection. If it pops up post-operatively, there's a concern that it might be resistant. If it's internal and we're talking more about our endophthalmitis, that's going to be a tap and inject, which means that a retina specialist is actually going to take some of the fluid and they're going to culture it. Central corneal ulcers, absolutely. Membranous or pseudoconjunctivitis, sometimes that's good to culture, especially if it's persistent. Preseptal orbital cellulitis, if it's possible, those are good for culturing, just to make sure. Post-traumatic infections, marginal, atypical. This is maybe why I said just culture everything, right? Okay, so this picture is coming in very slowly. I have no clue why, but this is one of those ones where it's actually not a great photo. I understand that, but it's got some satellite lesions, if you can appreciate that. And we have more of a fluffy border, and we get concerned when we have those fluffy borders because if you have more than one, even if they're small, you see little satellites, right? And they're kind of fluffy borders. You really should be concerned for fungal. And in those patients, if I don't have a confirmed, we know that the antifungal medication, the topical antifungal medication can be really, really damaging to the cornea. So if I have any sneaking suspicion and I don't have a confocal and I don't have the actual culture back, I'm probably going to go ahead and put them on oral diflucan, so an oral antifungal, just to help with it because that actually will work in these patients really well to help to control fungal ulcers as well. But if you're lucky enough to have a confocal, I had one previously. I think it's still at the university right now, but it's a giant paperweight because it stopped working, and I'm so sad. And they actually aren't making them anymore. We need to get somebody to start making these again because they're really, really helpful. Not everybody needs to have one, but it is good to have one in every location that we possibly can as far as like some one in each city because if you can send this to someone in your city to help figure out whether or not somebody has acanthamoeba, this is really, really helpful for diagnosing acanthamoeba, and then fungal keratitis. And that can be the difference between some of these patients permanently losing their eye cornea, because both of those can get really gnarly pretty quick. Other thing that it's used for, we use it for endothelial cell evaluations. If you've never seen a confocal, what a confocal does is it is essentially a really high-powered microscope, and it can take pictures all the way through every layer of the cornea so that we can look at them. I use it for Fuchs for endothelial cell count. I use it for my neurotrophic and neuropathic pain patients, looking at the actual growth and function, well, not the function, but looking at the growth, the size, the density of the nerve plexus within the cornea. But in such what we're talking about right now, we would be using it looking for the acanthamoeba or looking for fungal keratitis. And so when this is kind of just what it looks like when you're doing the full cornea, each of the slides, kind of the different layers. Here in C, you can actually see the nerve plexus, which is really, really cool. That's a whole other lecture. And then we've got our endothelial cells down here in F. But with our patients who have fungal, we can actually see hyphae. And these are fungal hyphae that tell us that we've for sure got a fungal infection. And so we need to be treating it like that. So that really helps when we have that. When we get into acanthamoeba, I have a lovely little picture or patient here. This was patient 2.5 who was diagnosed with an acanthamoeba ulcer. Monitored daily. Day number 2, we did an epithelial debridement, subconj, gent injection. But the big thing where I'm pulling this from is so that you can see that confocal. We can see these little cysts. We can actually see the cysts from the acanthamoeba, and you can see them here. Hopefully you can see my my pointer, but you can see these little circular guys here, and those are actually the cysts from the acanthamoeba, right? And so we know that this is a really hard thing to diagnose in general, and we know it can be really detrimental to our patients. But so we were able to identify it in this patient, lots of different cysts, these little hyperreflective cysts with spherical structures. We did thankfully get improvement in this patient, but at the end of the day, we never had any growth on cultures in this patient. Meaning we took many cultures on this patient at many different time points, and nothing ever grew for acanthamoeba. Yeah, that happens most of the time. You actually have to take a biopsy of the tissue and send it off, or you have to do a confocal, or you just have to wait till you get that lovely little ring and go, okay, we are going to, we now, can tell it has gotten that far that we have the ring ulcer. Okay. So with this patient, thankfully, by the time we get to final recovery, so we've got all sorts of things. We hit it hard. We've got our pool cleaner PHMB on there. Final recovery, all satellite lesions were healed at about 15 days. This was caught really early, thankfully. Following initial evaluation, we did cryopreserved membrane at 1 month visit, continued to improve. This is a long course of medication. PHMG was tapered weekly, 7 times a day for a week, 6 times a day. So was on it for quite a bit of time. Now, the other things to remember with acanthamoeba, this is a parasitic infection. It is specifically the Cancella. I'm not even going to try to read this. It's too early and I haven't had enough coffee. We've got a parasitic infection. Culture on dish of E. coli, it will show up, but most of the time, like I said, you're not going to get any kind of growth at all. Symptoms, these patients are going to have decreased vision. We know that the pain is going to be out of proportion with the findings, light sensitivity, redness, foreign body sensation, all these things that we find with any ulcer, right? Ocular findings, things that we're going to see is epithelial irregularities, some infiltrates, satellite lesions, stromal infiltrates. The big thing that we know is that ring-shaped disciform that starts to pop up, but that comes along way further into the infection in these patients, and we want to identify them in theory before that. So the things that we would be asking is, okay, um, hot tubs, pools, right? Things that we know about hot water, anything, showers, showering with your contacts in, with your eyes open and getting water in there, washing your contacts with tap water. Yeah, we don't want to do that, but we know lots of patients do. So if you have an inkling and you know that somebody in your area has a confocal, send it to them and have them do the confocal to look at it so that they can say yay or nay for definite we do or don't have acanthamoeba. Now, as I mentioned for these patients, what do we do for them? We're culturing, referring for a confocal if possible. Early stages, we're going to definitely hit it hard with antibiotics. Fortified compounded is usually what you need to do. Very often, meaning every hour to 2 hours, and waking up and putting them in. So these patients need to have the antibiotic constantly. May end up needing PHMB. That's what I keep mentioning, the polyhexamethylene biguanide, and chlorhexidine. These are the big heavy hitters that unfortunately are often needed. Debridement of the tissue is good because you can actually get rid of the cysts themselves when you're debriding. PK may be needed. Steroids, but you have to wait till the appropriate time to put that in there. And then the possibly cross-linking has been looked at as far as a way to kill the cysts through cross-linking. There's a lot of uh, studies looking at cross-linking. It's not approved at this point. Obviously, it's not used within the United States for this, but for not just acanthamoeba, but for other bacterial keratitises, it's something that's being looked at to actually help for that. Now, what happens if it doesn't heal? Or what happens if we get it under control and unfortunately we get a perf? Well, glue to hold it in place, right? This is unfortunately a patient who did perf on the right side that it plugged itself. So sometimes they self-seal, but then we still got to deal with it. If they don't self-seal and we see them in clinic, we do glue, and that ends up leading to the patient needing a cornea transplant, right? We want to avoid this if we can, but sometimes it happens anyway. So I want to talk about a patient recently of mine. So she had acanthamoeba May 2024. I didn't see her for this part. She was 15 years of age. They did a corneal biopsy. I think this was after unfortunately, our confocal went down. So they did a biopsy to actually diagnose it, right? So she went through all sorts of amniotic membranes. She was put on PMBG. She was sent over for a cornea transplant in the left eye right before I saw her. Vision is actually doing not great, even with a scleral lens, and you'll see why in just a second. Um, so this is findings, vision. The big thing I want to pull out of this is the vision. So when she comes to see me, vision is 2300 uncorrected 2080 in the right eye, with pinhole. That's the best we're able to get out of her vision, even with a scleral too. And I love sclerals. I'm not the one who does them, but I love them because they do so much. Other eye, we get her down to 2200 with correction, pinhole 2400. And this is after a corneal transplant. So prior to transplant, this is what the eyes look like. Okay. So we've got the left eye on the right side. So that right side picture, she ends up with a corneal transplant. Unfortunately, you see all that neovascularization. We know that she's going to need a transplant. The other eye, not too bad. She's got all of this scarring, right? So she was sent to me. This is essentially what she looks like when she's sent to me and said, "Hey, Ketting, can you work some magic?" So there's been some studies on topical compounded losartan, zero point 0.8 mgs per mil, using 6 times a day for about 3 to 4 months. So we did that, and she came back to me 2 weeks ago, and her vision with a scleral lens, 2100 without the lens, and with the lens, 2020. One, scleral lenses work magic, but two, look at that cornea. Oh my goodness. Yeah. So this was her on losartan for 4 months. You can tell, here, I'll flash back. That's where we were. This is where we are. Pretty awesome. And I've got a number of other patients that are on it. I had another patient who came back in that same day who had been on his losartan for 3 months. He looks better as well. He's not quite where I want him, so we're going to go another 3 months to see if we can get him better. He also has hypermature cataract, so we're trying to stabilize that before we go to do his cataract surgery. But it's pretty cool. So I just had to throw that in there because that was recent and that made me really excited. So let's switch it up. What happens when we have an acute IOP elevation? So we have a 75-year-old white male, right eye pain, 7 out of 10, nausea, went to the emergency department yesterday for a headache. Notes that it has had some intermittent right side pain and headache on and off since the beginning of the year. So let's see. What do you look like? We've got vision counting fingers in that right eye, 20/60 in the left. We check the pressures. We've got a 59 in the right. So we've got 17 in the left eye. In the right eye, we've got, other than some blepharitis, 3+ injection, 2+ gutata. So we've got some swelling of the cornea. We've got 1+ cell and flare in the AC. Lovely mature cataract. Left eye, we've got 2+ gutata as well. Deep and quiet, 2+ NS, 1+ CS. Posterior, we can actually see. So we've got a 0.4. Everything else is looking good back there. So what's going on? Well, this is an angle closure, right? But this is a lens-induced glaucoma. And this is because of this patient's mature cataract. And we know that as cataracts progress, they become larger, right? The lens increases in size, and then it starts to actually push up. So some of our patients who have a narrow angle and we know have a risk for narrow angle glaucoma, this is a concern, and why sometimes we elect to have earlier cataract surgery with them is because we know that as it continues to grow, we have a much higher risk that it's going to close that angle. So lots of different things that can be part of this, but essentially leads to pupillary block, plateau iris, angle closure can caused by phacomorphic atopial lentils. Open angle, if we have an open angle in these patients, we can also get phacolytic, meaning the lens, as it gets mature, starts to break down, and these particles get into the meshwork, and that starts to block it. And then we get increase in pressure, and so it's not actually an angle closure in that sense. It's an issue with the angles being blocked from the material that's made its way into the anterior chamber. Other secondary issues that can happen, we know, are fibroneovascular or uveitic, and we'll talk about one of those in a minute. So we already looked through this. Yep. So this is what's going on in the patient. We do a gonioscopy, open to CB in two quadrants, partial TM in two quadrants, and shallow 360. So overall, we're deciding this patient is phacolytic glaucoma. So for the patient, we go ahead and start lowering the IOP. Honestly, we know sometimes, let's be honest, it's whatever we've got. Ideally, we want to do things that are going to be aqueous suppressant or we want to think about improving outflow and aqueous suppressant depending on what the etiology is. We want to avoid a prostaglandin because that is pro-inflammatory. But again, sometimes it's whatever you got in your office. So this patient, timolol, bromonidine, dorzolamide, and oral acetazolamide. Rechecked the IOP in office and repeating rounds of the medication every 30 minutes as needed. Finally got him to 50, and then 7, right? And the next day was back up to 38. So the patient was actually transferred to hospital scheduled for urgent cataract extraction. Again, depends on modality where you're working. My previous practice, it's not like they're going to the hospital. We had a operating room upstairs. One of my surgeons would probably just take him upstairs and do it. I work in a hospital now, so that's where he went. Patients admitted inpatient care due to complexity and other things with transportation. So that's also comorbidities and where do they live. A lot of our patients do get transportation, so I think that's why this one was put back in there. So other considerations with these patients, right? Actually, let's go back to this. So patient ends up having surgery, ACIOL's done. Afterwards, we're now able to actually see what's the best potential vision for this patient. Gets down to pinhole of 2025. We're finally able to get some testing because now we're out of the emergency situation. Let's see what our baseline is. And we can tell definitely, this is not a primary glaucoma in this patient. This is a secondary issue from the lens, that phacolytic issue, because look at the asymmetry, right? And if you hear me do neuro lectures, I talk about secondary glaucoma a lot and how it's usually related to other things. And we now know what's going on in this patient, right? So we've got the right eye has a fairly decreased visual field. We've got a nice superior arcuate defect there. Left eye, maybe a little early nasal step. Question would be maybe does this patient have some risk over there or what else is going on? But also we can look at the RNFL and the optic nerve head and see that we've got a significantly diminished RNFL in the patient as well as a decreased GCC. So I kind of wonder how long it was going on. So other considerations, right? So when we see these patients, we have to look at these different things. Are we seeing 50 millimeters of mercury or higher, shallow anterior chamber versus peripheral anterior synechiae, pigment clumps and TM? Are we seeing corneal edema? Is it a fixed and dilated pupil? Are we having some ciliary flush? Looking at what's their age, right? Is this a patient who's going to have a mature cataract? Will there have been potentially if we see a mature cataract in somebody who's in their 30s, I'd be worried about some kind of trauma, right? Which would then also make me look at the iris itself and doing gonioscopy and looking for some damage there. That could also be part of it. Is the patient on any medications? We're going to talk about that in a second. Looking at refractive error, because we know that can put some patients at a higher risk for angle closure. So with angle closure glaucoma, we do know that it tends to manifest between the ages of 55 and 65, and prevalence does increase with age, and that's likely and due to that increased thickening of the lens along with age, as we were talking about. Gender does, some studies do indicate that females have a 2 to 4 times higher incidence rate of acute angle closure than males. The race predilection, it's more commonly observed in Southeast Asian, Chinese, and Inuit patients. Really relatively uncommon in Black populations or African Americans. Yes and no. I think it depends on where you're at because I really all of our demographics are different based on where we're practicing. So let's, I want to go into two other thoughts on acute angle, a couple other patients that presented differently. So I had a this is literally probably first 3 years of practice for me. So this definitely caught me off guard. So this patient was 65-year-old Caucasian female. She came in, she's presented yesterday. She went to the emergency room. She presented to us for an emergency evaluation. She had bilateral swollen eyelids, vision loss, new onset of stabbing pain across the brow for the last 3 days. Symptoms began 12 hours after taking the first dose of a new drug to her, casemia, and it's she took it at 10:30 a.m., 12/31/14. Yeah, this really was in the first 2 years of my practice. Oh, this is funny. So the patient reports not having taken any other dose. So she took one dose of this, stopped. She started having eyelid swelling, pain, vision got blurry, went to the ER, and they gave her IV and oral Benadryl with no improvement, right? So they're like, oh, you're having an allergic reaction. I immediately am looking at the swollen lids. I'm like, ooh, is this cellulitis? What's going on, right? Patient had both a head and orbital MRI with and without contrast. Everything was fine. Okay. Big, bad, and ugly. Patient has noted some relief in pain since being prescribed pain medication, but no improvement in the other symptoms. Not surprising, right? Because we're all sitting here going, well, what else is going on? So, pinhole, no improvement. Light perception, both eyes, not good. Painful movement, both eyes. Pupils, I couldn't see them because she's got this horrendous corneal haze. I mean, she's got tons of swelling of the cornea. Intraocular pressures of 50 and 40, and Packies are 802 and 783. Okay, so we've got an issue, right? 2 plus edema, erythema, and 2 plus lid edema, conjunctiva, chemosis. Like she is just swollen. I don't have any pictures from this, and I'm bummed. I did go back to look, but she was looking. I do remember she was looking pretty gnarly, and she was feeling awful. So we've got all of this stuff, right? We can see that she's got a pupillary block. She's got peripheral iris, corneal touch, about a 1 plus ENA, so she doesn't really have any cataracts. And the everything else, attempted gonioscopy, but really hard to do because of one, yes, you can get around seeing through some of the corneal haze if you tilt and adjust, but she was just really, because of all the swelling, she was really uncomfortable. So what did she happen? She has topiramate-induced bilateral acute angle closure glaucoma with a ciliochoroidal effusion, second to the use of her casemia, right? So we had to do some digging, right? We could tell that she had some angle closure, the pressures are up. That's leading to all of the issues with the swelling of the eyelids, the conjunctiva, the cornea starting to become hazy. So we start to try to work to get the pressures down. So we did 3 rounds of Alphagan, Istalol, Lumigan, 5 minutes apart. We did a subtenon's injection of Kenalog, and then we did an emergency YAG PI in both eyes to try to get the fluid to be able to move through, right? Continued the at-home use of Lumigan, Simbrinza, Istalol, and Durezol. Like I said, sometimes you just use what you got and you throw it till it sticks because you just need the pressures to come down. We also put her on a Medrol dose pack, so steroids to kind of start to bring down a lot of this inflammation. Next day, she comes back. She's now counting fingers, 1 foot, both eyes. Pressures, 16 and 18. Okay, we're back in a normal area. 1 month later, she comes back and we've got her down to 20/50 in both eyes. She does have significant cataracts, so we later treat them. But So this Casemia drug, it was approved in FDA by the FDA in 2012 for weight loss in overweight adults who are diagnosed with hypertension, type 2 diabetes, hyperlipidemia. Now, the problem with it is because it actually is a combination of phentermine and topiramate. This patient had never had a sulfa drug that she knew she had an allergic reaction to, but essentially this was a sulfa-based medication having a sulfa-based angle closure, right? We've heard about those. This is a new drug that I'm like, what is it? I had to go look and figure out what was in it to figure out that that's actually what was happening, was she was getting an acute myopic shift and acute bilateral angle closure glaucoma. So I have not since that seen that drug be used by anybody. It's not pulled off the market. I did check a couple like a week ago when I was finishing this lecture up. And it's still out there, but I don't really ever see it. And frankly, now with the GLP-1s, I don't know if we will see it because those have kind of taken over that part of the market. So what about this in a different light? Another type of acute IOP elevation. So we have 56-year-old African American male. Chief complaint is red eye with an elevated pressure in the left eye, right? So he's had blurred vision, ocular discomfort, and redness for the last month. Now, apparently, it's so bad that he actually wants to be seen. We always know how that goes. Treatment with, he's been given fluoromethalone 3 times a day with no improvement, actually caused an IOP spike. Suspected steroid response at this point, and it's coming in to see us. We're kind of going based off what we got because we were an emergency referral center. Started on bromonidine, left eye, timolol left eye to try to get it down. IOP remained elevated with no improvement in the symptoms. So now the patient's off of the steroid and on these in clinic, but we're not getting an improvement. Huh, okay. So let's look at the other information. What's going on? Maybe, there we go. Does have an ocular history of herpes simplex keratitis, other systemic history, hypertension, kidney transplant in 2008, is on medications for that for anti-rejection, right? So we've got amlodipine, aspirin, calcium, calvodile, clonidine, Envarus, finasteride, fish oil, myofortic, omeprazole. Nothing stands out, right? It's like, okay, we see those all the time. Exam findings. 2025 in the right, 2060 in the left, pinhole to 2030. Pupils, normal, EOMs full, CFF full, IOP 1434. So we've got an elevated pressure. Okay, what does the anterior segment look like? Cornea on the right eye, which is the one that's not having the problem. We have a superior stromal scar and some fibrovascular pannus. Otherwise, pretty normal. Left eye, we've got 1+ injection with ciliary flush, 2+ haze, 2 to 3+ SVK, diffuse fine KP, right? You see where we're going. Subtle diffuse stromal scarring. Got 2+ cell, 1+ flare. Okay. Elevated pressure inflammation. Think viral, right? Anytime we see uveitis with an elevated IOP, we want to think viral. Most often, we're looking at HSV or we're looking at shingles or zoster. Less often, cytomegalovirus. We really, with the heart drugs and good control of HIV, we aren't seeing cytomegalovirus really. Typically, if you do, it's an immune compromised patient. Same thing with rubella. Anterior chamber tap or PCR can help make a definitive diagnosis, but most of the time we aren't doing that. We just look at the history, we understand what's going on, we look at the clinical presentation and say, yep, this is probably viral, and guess what? We need to treat it as such. Especially, we had the benefit of seeing that this patient went on a steroid and it got worse, or the pressure went up, and we put them on pressure drops and it's not lowering. And that's because if you look back at what was given, this patient, so the etiology in these patients more often is you actually end up with inflammation in the trabecular meshwork. So it decreases the ability for drainage. And so in that case, you actually need to put them on a aqueous suppressant, something that's going to decrease the aqueous production because you can't increase the outflow because the outflow is swollen, right? So most commonly, how do you tell between simplex and zoster? And you're honestly going to kind of treat them the same anyway. Looking at age, I don't think that's the case anymore, considering I'm a human sitting here with shingles who's had shingles. Well, I don't have it right now. I've had shingles flare-ups once a year for the last, I don't know, I'm in my 40s now, since I was 30. So yeah, we know that that's not quite the case anymore. So don't look at that. Um, Typically unilateral, can be bilateral, but more often for both of these, it's unilateral. Corneal scars will indicate that they've probably had something before, but otherwise, it's really no differentiation, and it's okay because most of the time you're going to treat them very similar. The only difference is obviously we know when we talk about our antivirals, the difference in the amount of antiviral that you're going to give them. Sometimes you just kind of go on the higher end because you don't really know. History of HSK and presence of old scars, really highly suggestive of HSV in this case. So we want to be sorry, I'm thinking. So highly suggestive of herpes in this case. So when we see those things, we want to start thinking of HSK for this patient because we know that he's previously been diagnosed. So somebody did just ask, why are we seeing shingles in younger patients now? Babysitter and my brother had it in their 20s and 30s. Ha! So most of us that are getting shingles younger, part of that is the introduction of the chicken pox vaccination. And this is the theory. This is the working theory as of right now. So, chickenpox vaccination means that there's a generation behind me. I'm too old for it, I didn't get it, right? That received it and so never had chickenpox. And the thought is that the adults, when children would have chickenpox, right, which we know is the initial primary infection of shingles, when the children would have chickenpox and we would be around them, our immune system would get a little boost. And so we would continuously kind of have secondary exposures that our body would be able to keep us from having any kind of um, uh, flare up, right, or actual issue, but it would help with our immunity and continued. And now that we don't have that next generation that is getting the chickenpox and we're not getting a secondary exposure, we're not actually continuing to keep up our natural immunity state. So that's the thought as to what's causing it, and that's from lots of personal research because I'm like, can I please just get the shingles shot? And they're like, no, you're too young. So we got another 8 years. So, herpes simplex virus can cause up to 5 to 10% of all uveitis cases, more common in patients who previously have had this, which makes sense, right? Clinical signs, unilateral. As we just saw, they're very similar, but this specifically, we're talking about HSV. Moderate anterior chamber reaction, medium-sized KP, elevated IOP. Like I said, we're getting a trabeculitis, so we're inflammation of our trabecular meshwork, and that blocks the meshwork with inflammatory cells as well as the areas inflamed. Sectoral iris atrophy can develop later. So we may see that later after, and that might be a good indicator that a patient has already had this. So if you see that in somebody who's exhibiting these signs, it's probably a good indicator that it's now a secondary flare-up. Our KP, our sectoral and iris inflammation, and that atrophy that will occur later. Now, what do we do for these patients? We're going to put them on a topical steroid, right? We're going to put them on an oral antiviral, depending on if we know if it's HSV or if it's shingles. And then topical IOP lowering drops, as I mentioned, aqueous suppressant, so that we can actually decrease the aqueous that's being produced. So back to our patient, diagnosed him with herpes viral iritis cyclitis, started him on pred 4 times a day, ganciclovir gel, valacyclovir. You could do with the ganciclovir gel or not. I argue, so this was my resident who decided that, and I said, sure. It's part of learning. We try things. I would argue that the ganciclovir is more for external, like our keratitis, and it's not actually going to penetrate inside, but she wanted to try it. I said, that's not a problem. Say this day and age, it's not exactly easy to get it, and it's not usually cheap. So maybe don't do that unless maybe you have some around amazingly. Ocular hypertension, timolol, bromonidine, central corneal scar in the left eye was likely secondary to previous herpetic events, and then putting our patient on preservative-free artificial tears. So why did we reduce, if you look at it, we did 500 milligrams of valacyclovir versus the traditional 3 times a day. We only did 1 time a day. The reason being is, remember, this patient had had a kidney transplant. So we did call the patient's nephrologist and say, okay, how much can we do? What is our okay level here? And they said 1 time a day. So that's what we went with. 60-90% of the drug is actually excreted by the kidneys, and it can solidify the nephron tubules, leading to an issue called crystalline nephropathy. And since this patient had that kidney transplant, we decreased it just to make sure. And then we monitored the creatine and blood urea and nitrogen while they're on the medication. Okay, no more IOP. Let's move on. Let's talk about some red, watery eyes. That's another thing that makes us very excited, right? 24-year-old Caucasian male, sudden decrease in vision, red, watery eyes worsening over the last few days, started in the left eye, then spread to the right. Eyes are light sensitive and painful. No ocular history meds, no systemic meds, no contact lenses. Right, so we got to ask. BCVA, 2040, 2060, anterior, both eyes. We've got 2+ lid edema, 2+ chemosis, pseudomembrane with fornix shortening, cornea, 1 to 2+ SBK, no SEI. AC is clear, does have swollen preauricular nodes. So we know where we're going with this patient, right? Couple of those buzz things you see, my pertinent negatives, as well as my actual positives, right? We've got swelling, subconch hemorrhage, we've got edema, we've got a pseudomembrane, right? That pseudomembrane's a big one. No SEI, right? So I'm thinking viral here, right? But this could be all sorts of effects, right? When we talk about red eye or red watery eyes, there's so many different reasons. These are some of my patients sending me photos because they've got a red watery eye and saying, can you diagnose me, right? So depending on what's going on, like these are a little bit more ambiguous. I can't tell, could this be scleritis? Could this be episcleritis in the patient on the right? It looks like it's maybe sectoral. Could she just have rubbed her eye? I don't know. Come in. I got to see you. I really have no clue. The patient on the left looks a little bit more diffuse. Again, you don't know, because what is the eye's natural reaction when something's going on? It's to be red. So it can be a plethora of different things. And then you've got these patients. Subconch heme. Easy peasy. We can deal with that. That's enough. Come in. We'll still look at it, make sure things are okay, make sure they didn't have any trauma like our first patient. But um, red watery eyes can be so many different things. So let's go back to our patient. This is him. Not great photos. And that's because it was really hard to get him to sit still because he was so uncomfortable because of those pseudomembranes. But you can see down in that bottom photo over here, that yellowy stuff, that is actually a pseudomembrane. And what happens and why that's painful is because a pseudomembrane is shortening the fornix. And so every time the patient's eye is moving, it's pulling on that. And so you're getting this really nasty pain whenever they're moving their eye, or honestly just all the time. It causes aching, and then plus all the swelling that's here. It's a really tight tissue. When you get swelling in a tight tissue, that can absolutely make it painful as well. So guess what? Yeah, viral conjunctivitis. Adenovirus. There are 6 subgenera, 53 serotypes. This is not including HSV or shingles conjunctivitis, right? Those are also viruses, but we're talking adenovirus specific. This is kind of our flu, right? It's the eye flu, and they can have fever, fatigue, or flu-like symptoms. Guess what? This can also be COVID. Yes, and we won't know without testing. Signs, they're all going to have chemosis, follicles, swollen lymph nodes, may or may not present. I find that if somebody has swollen lymph nodes, it's a really hardy virus and it's going to persist for longer, and they're going to have a lot more like pseudomembranes, SEIs or subepithelial infiltrates. Those will more often be in the presence of swollen lymph nodes. And that just has to do with what strain or what serotype it kind of caused it. This is me. Yay! Doctors get it too. It's fun. I've had it 3 times. I promise I'm a clean human. The first time happened from sharing a slit lamp during residency with one of the ophthalmology residents. I was in retina. I looked after him. He got sick, showed signs a couple days later. I showed signs about a week later. That was fun. This one was, I don't know, who knows? There's a whole it is so easy to contract, which is the hard part, right? And we've got our SEIs. Now, if you see these little guys can persist for up to 8 to 12 months in patients. It's not always, but they can persist for a very long time, which means you're going to be on treatment for longer. Highly contagious, can live on third-party objects for up to 72 hours. I touch my eye while I've got it. I touch a grocery cart or something at the gym, and then somebody does the same thing. There you go. That's how you get it. Adenoplus, so that is the little test that we have that can test for the adenovirus, right? So looks kind of like the inflammatory or a little pregnancy test. But you have to remember, if it comes back negative, it doesn't mean they don't have it. It only tests for the most common serotypes. So it only tests for 6 different serotypes. And we just said there's 53. And that doesn't include COVID or our patients who may have HSV or shingles. So if it comes back negative, that doesn't mean that's not what they have. Okay. You have to look at the clinical signs. Do they have follicles? Do they have membranes? Do they have SEI? Do they have swollen preauricular nodes? Honestly, follicles are the big thing. You know it's viral if you got follicles. Rule of sevens, remember it's contagious for 7 days prior to signs and symptoms, which is another reason it's really easy to pass. Contagious for 7 to 14 days after signs and symptoms. Typically, we'll start in one eye and then it will go to the other eye. That's one thing I ask my patients, even if they come in with both eyes having a problem, and then I'm thinking, oh, is it allergies, right? Did it start in one eye and then go to another? Allergies don't do that. Allergies are in both eyes, typically at about the same time, unless it is something that they were exposed to as far as like a drop or something that they put in or something very random. But more often than not, it's bilateral at the same time. Signs and symptoms will persist for about 21 days after they start. Now, what do we do for these patients? In office, you can do a betadine wash. You can remove the membranes. Both can be controversial. If you have a patient who is showing symptoms in one eye and not the other, you can betadine both just to decrease the risk. It will help decrease the viral load. Removal of the pseudomembranes. Yes, you are creating essentially, you're going to peel it off and that will leave a little open wound. And so I usually put them on kind of a Tobradex ointment or tobramycin, dexamethasone, something that's got an antibiotic and antibiotic and a steroid in there. And that will help with comfort, but also decrease any kind of risk of infection because when you pull the membrane off, you do get a little wound that's left. At home, topical antivirals, nothing's been shown that that actually does anything. In theory, maybe it decreases the viral load. Topical NSAID to help with discomfort and the swelling. Same thing with topical steroid. Some people have argued prolonging of viral shedding. We haven't, again, shown anything definite in that. I do use topical steroids in these patients usually twice a day for 2 weeks until I see them again. I get them out of their contagious period, and then I'll look at them again just to make sure how they're doing. Now, if they have SEIs, like we were talking about, those little subepithelial infiltrates, the little white spots, you may need to keep them on that longer. So you have to watch it. Lots of lubrication with cold artificial tears and cold compresses. So when we talk about a betadine wash, this is a betadine wash. I've had it done to me twice. Once someone remembered to put an anesthetic in, once someone did not. I'll tell you which one made me very happy. But essentially, you're using betadine, and it's the same thing that they do prior to intravitreal, or a lot of retinal specialists do prior to intravitreal injections. You put a numbing drop in, then you put a couple drops of betadine, like 3 to 4 drops. You have the patient roll their eyes around, right? So it gets spread all over, and then you flush it out. You flush it, flush it, flush it. And then make sure that they're using artificial tears and things because it will really irritate the epithelial cells quite a bit, which is why there's some ups and downs of doing it. If you have not seen the Quidel inflammatory or the Quidel adenovirus test, that's what it looks like down there in that corner. That is the little test. But remember, if it comes back negative, it doesn't mean that they don't have a virus. Okay, so let's shift into another thing that makes us all happy. Got double vision. Yep. Oh yeah. Someone just asked, do I put them on a steroid after the betadine wash? Yes, I do. I put all my viral patients, whether regardless what it is, it will help with a lot of the symptoms. Um, if they've got viral conjunctivitis, it will help with a lot of the swelling and discomfort. So yes, I do put them on a steroid. That also helps, especially after a betadine wash. I have a couple patients where we have to go on that even after they have intravitreal injections, just because the betadine can um, be a really bad irritant. How do you know if an SEI is old? Well, it's not old if it's there. It should not exist. It doesn't leave a scar. So SEIs will resolve completely or they're not gone. If you still see them, it means you've got some active inflammation. Hopefully that's helped. Okay. We have a 68-year-old sudden onset of diplopia along with a left eye lid droop starting 4 days ago. When the lid is lifted, diplopia resolves when either eye is covered. The images are diagonal to each other, and the patient is an uncontrolled type 2 diabetic with for 15 years. Last A1C 3 months ago was 12%. So when we talk about double vision, first questions we need to ask is, when you cover one eye, does it go away? If they say no, and I'm seeing double vision out of one eye, then okay, is it an uncorrected, um, it could be an uncorrected astigmatism. It may be that they have something going on cornea wise. It could be lens or it could be retina, right? So we start thinking different directions. If you cover one eye and it goes away, okay, we've got probably something going on more neurological. So then we want to ask them, are your images side by side? Are they overlapping? Are they catty corner? Or are they up and down? So when we kind of have that idea, then we start thinking about what nerves are the issues. So this patient had a corneal nerve 3 palsy. Remember, we've got eyelid involvement. So the eye is turned down and out because cranial nerve 3 controls everything except for the lateral rectus or the superior oblique. When those two are still functioning, down and out. The eyelid is shut, levator, and it may not be complete, right? You can get a partial on any palsy. You can get a partial. So the levator pupilla is the lid retractor that is innervated by cranial nerve 3. So if that's out, we can get a little partial palsy or a full palsy, so paralyzed, leading to ptosis. Possible pupil involvement. We know that this is where we get really concerned. Um, Pupil sparing is a normal reaction. Non-pupil sparing, the affected pupil is not reactive to light and shown in either eye. Now, with that, the question is, how long has this been going on? If I have a patient who comes in and is like this and is like, it's been 6 months and I see no pupil involvement, I'm less concerned than if I have a person who says this started 24 hours ago and I look at them and the pupil is not involved. It may take up to 72 hours for pupil involvement to happen. So you have to watch those patients closely, and that's why it's important to understand how long something's been going on. I also would like to ask, why have you been seeing double and like this for 6 months and you're just now coming in? And why is this an emergency? I love those. So this is a really cool, I love Root Atlas, opthobook.com. I do have their permission to have this. I actually reached out to them because I love their photos. So this is a great way to think about it and why we get concerned when there's pupil involvement. So with cranial nerve 3, most commonly, the most common cause is vasculature. And with that, I mean our hypertension or our diabetes, something that's going to affect vasculature or permeability to the nerve itself. We get compromised there. The nerve's not getting the blood supply it needs. It stops functioning properly. The most common causes of that, like I said, diabetes, hypertension. And the vasculature runs inside the cranial nerve, right? Now, the pupillary fibers, the superficial parasympathetic fibers, run on the outside of the cranial nerve. And more often, if we have pupil involvement, it means we have something compressing from the outside that is affecting the pupillary fibers. That's not a hard and fast. Can you have pupil involvement with somebody who has a severe long-standing or a severe cranial nerve 3 palsy from hypertension, diabetes? Yes, you can. But more often, this is where our brains are thinking and why they're thinking that way. So pupil involvement potentially implies a tumor, aneurysm, something compressing from the outside. Non-pupil involvement implies something like diabetes, hypertension, something ischemic, something affecting the nerve from the inside. But as I said, it can take up to 72 hours for the pupil to become involved. Now, what do we do for diagnosis? In office, test versions, ductions, prisms. You want to look at the pupils, EOMs, ductions, forced ductions. So don't forget about forced ductions. Do I have a picture? Yeah, we're going to talk about it. Outside office, if there's no pupil involvement, blood pressure, blood work. I get the blood pressure in office just so I can see where they're at that point in time, because we know with A1C we get an average, but with our hypertension, we don't have an average, right? We just have multiple points in time. So if you can get that while they're there, that's great. If they say that they're not diabetic, I'm going to get A1C and I'm going to get fasting blood sugar just to see where they're at. Monitor for pupil involvement. If you have an ick factor and you just don't feel comfortable with it, send it to, you can send them for an immediate MRI and MRV, even if pupil's not involved, if it's a new onset and you just are concerned and know the patient's history. Say it's a 20-year-old who's not diabetic, probably doesn't have blood pressure issues, but they have a non-pupil involved that started 24 hours ago. If you just feel uncomfortable with it, you can send them to the ER to have the MRI and MRV. Versions inductions, when I talk about that, this is a little bit different way to do it that I was taught from oculoplastics when I learned from my mentor. And so it's essentially using a muscle light, and I'm actually just going to get to the video of it. So using a muscle light, pen light, you're watching where the Purkinje image is in these patients and where it's reflecting. And based off of that, you kind of make notation of what their measurements are. So you have them look in each corner. Yep. And then we notate it like this. This is what's considered normal, right? Based on the natural anatomy and restrictions that we have with gazes. And outside this, we start looking at where the Purkinje image is reflected. And that's where we actually get the numbers that are reflected in there. And then forced duction, I don't use tweezers or forceps. I will numb the patient up and I will use a Q-tip. It works just as well. But the idea is here, what we're trying to do is we're trying to push the eye in a direction that it doesn't want to go so that we can see, is this something that is orbital, or more likely orbital, restricting the movement because there's something physically blocking the eye, or is it neurological? And this is with any palsy, right? If we're having an eye that's not moving in a direction it's supposed to, these tests are something we're going to do for any of those so that we can kind of get a better idea of what's going on. Now back to our patient. So our patient ended up having an aneurysm that was causing her cranial nerve, or his cranial nerve palsy, within the cavernous portion of the left internal carotid, measuring 1.8 by 2.2 centimeters. It was grossly stable compared to a previous study. Apparently there was a previous study. I'd say not stable because now he has a cranial nerve palsy. So there's a little argument on that. And typically with aneurysms, interesting enough, many times they get left alone and they don't do anything as long as it's not symptomatic or causing problems. Many times they'll leave it and watch it. Now, what do you do if you get this MRI back, you order it, you want to look at it, and you're like, well, now what do I do with it? If you have somebody who has a compressive lesion, that needs to go to a neurosurgeon, not a neurologist. If you have a compressive lesion or a lesion in general, that goes to a neurosurgeon. If you have an aneurysm, it goes to an interventional radiologist. Took years for me to realize this after sending it to wrong people and people going, why did you send this to me? So I'm passing on my wisdom. This is another patient. This was a patient who was 26-year-old female, came in with blurred vision, left eye for the past week, 3-month history of headache behind the left eye. Vision was 20/20 in the right, 20/50 in the left, IOP 16 and 18, so normal. Color vision was severely deficient in the left eye, and the pupil she had a slight APD. CDs were pretty normal. So we sent her out and she had an internal carotid aneurysm, and this one did require urgent stenting. So kind of interesting. Now, what does it look like to actually read a report? So when you get these back, it'll tell you what it is, your MRV, MRI, whatever you're looking at. And essentially what you're going to is you're looking down and going to the findings and impression. More often, you're going to avoid the findings. I like the findings because it's kind of interesting to read it and see what's there. So it says normal appearing superior, inferior sagittal sinuses, normal bilateral transverse sigmoid dural sinus, visualized upper jugular. This is a normal. This is a normal patient. That's lovely, right? Impression, usually it'll tell you, I think it's XYZ. This needs XYZ, or it is stable compared to a previous, or, this is what needs to happen, right? It won't tell you necessarily who to refer it to sometimes, but depends on the radiologist. Some of them are more helpful than others. So let's look at this one. So we've got overall, everything kind of came back normal. Again, you can just skim down and go to the impression, which says no evidence of acute infarct or acute intracranial finding, no evidence of intracranial metastatic disease, which is good. There is a new tiny chronic left cerebellar infarct, small right basal ganglia, chronic lacunar infarct, slight progression of white matter signal changes like chronic microvascular ischemic disease. That means this patient's probably a little bit older. Doesn't mean anything. All that's not abnormal. There is a 1 centimeter enhancing skull lesion posterior to the frontal skull. Further evaluation, nuclear medicine bone scan suggested to evaluate for other lesions. So, what does that mean? They found a small lesion within the skull. There's a concern that it might be some kind of cancerous bone mass, right? So that's what they're asking for me to kind of send it off to get evaluated. The other one, this one said findings. There are no areas of restricted diffusion. Everything's pretty normal. Brain, parenchyma, new chronic infarct posterior to the left cerebellum. So, like I said, you're just looking through and looking for what they're saying is abnormal, and then sending it off to the person that they need to. A lot of times you guys aren't probably, and I don't always get these back, but it's good to look at it just so you kind of know where to kind of skim down to. Get to the impressions. That's the best thing. Okay, so we've all heard this. So I started to notice these weird spots in my vision. Should I come in? Could be squiggly lines, floaters, cobwebs, blobs, gnats, worms. I don't know. We've heard all sorts of things, right? And so flashes and floaters, we want to ask them, what are you noticing? Are you having flashes? How often? When? Curtain, veil. These are great for our staff to know so that they can ask them over the phone because it tells us should they come in now or later. Is this a flash that you're seeing that started yesterday or today or a week ago or a month ago versus has this been there for 2, 3 years? Are you seeing floaters and these have been there for 2, 3 years? Or are you seeing new floaters, no flashes? All that kind of gives us a direction of where to go. And then, of course, that curtain or veil decreased vision really kind of brings that home. Flashes and floaters. This is a patient who came in with a MAC off retinal detachment. This is one of the things we have to figure out. MAC off automatically makes it less of an emergency to our retina specialist, right? So MAC on is a bigger concern for them because there's a risk for it to the macula to become involved, especially if it's a superior retinal detachment. That means that there's a risk that gravity will bring it down and the MAC will get involved. So those usually my retina specialist will get them in for surgery within 24 hours at most. Sometimes it's like depending on what time of day it is. And I call them and if they haven't eaten, they're going to just pull them straight in and take care of it. The MAC off, unfortunately, worst case scenario has already happened. They're still going to do the surgery pretty soon, and it depends on if they have an opening that day. And they may still do it that day, but it's not abnormal if they see that patient or you send them this photo and they go, okay, cool. I'll see him in tomorrow or I'll see him in 2 days. And it sometimes just depends on the retina specialists themselves. They all have different levels. Now, this is one of those, you're probably coming in today and we're going to do surgery right now. We've got a nice little tear you can see in the superior area, and we've got this rolling clouds of thunders superior that are starting to encroach inferior. So this patient had surgery immediately. This is a lovely rolling cloud of thunder. We don't know if it's MAC involved. What is the patient's vision? What does the macula look like? Photos are great. They're kind of fun for you guys to look at, right? But we need to know, what is the vision? Is this patient 20/20? This patient 2400, counting fingers? That would tell us more likely whether or not, especially if we don't happen to have an OCT, whether or not it's MAC on or MAC off. If you have an OCT, absolutely get an OCT on this patient. So what about our patient? So we've got an 18-year-old female who was referred from Cheyenne for an evaluation of possible retinoschisis versus a retina detachment. So we get a lot of patients who come down to Colorado from Wyoming. Patient reports flashes and floaters in the right eye since last Thursday. So it's been, I think this is probably a Monday, would be my guess, knowing my schedule. Has chronic floaters, but they may have increased. She's a -9 myope. Okay, so we've got a high risk for retinal detachments already in this patient. She's saying that she's got flashes. The doctor who saw her said probably potentially retinoschisis, maybe an RD. Can you look at it? Either way, they're not going to treat it up there. They're going to have to send it down to us. So exam was done. We do see that there is a temporal hole, lattice superior, and lattice in the left eye as well. So this is our patient here. So you can actually see the little hole and lattice that's over off on the side to the left. Okay, so what do we do with this patient? Here it is zoomed in a little bit. We need to take care of it, right? So patient went to retina. Fun thing, they did a scleral buckle. No, this was not 1990. This was this year. Why a scleral buckle? You'd have to ask the retina specialist because I don't see them done very often anymore. And it may have been, honestly, she's 18, she's a -9. They were probably hedging bets on the fact that she's potentially going to have it happen again, or because she's got such a high risk. I don't know, but I don't see retina specialists do these very often anymore. But they do. And so a scleral buckle, remember, the idea is we're actually cinching down the eye itself to kind of bring the circumference of the retina, decrease the circumference of the retina so that it can actually kind of help hold it in place and bring the retina back up, and it decreases the risk of reoccurrence. And again, that may be why they decided to do it in this patient. Other things that are typically done, laser retinopexy, and this was done in her other eye, and this was done to surround the area of lattice that she had to decrease the risk that she would actually have the same thing happen in the other eye. But most often, what's being done at this point is pars plana vitrectomy with a retinal repair. So removing the fluid in the eye, and then they use air or oil to increase the volume within the back of the eye, essentially pushing up the retinal detachment tissue back into the area where it's supposed to be, and usually using some laser at that same time to kind of tamponade and tack that tissue back to where it's supposed to be.
Specialist based out of Denver, Colorado.
So this is one of my local retina specialists who takes phenomenal pictures and videos and loves to share them to our benefit, right? So he's going in and getting ready to do a pars plana vitrectomy in this patient, and you can see that retina detachment over in that area, right? So now he's actually sucking out the vitreous and preparing. And then now he's actually pulled it all out. He's pushed the air in, and so we're pushing that tissue back.
Trying to laser under air.
So he's trying to laser to tack it down.
Even when some retinal fluid is present. As an alternative,
Don't want to give anybody a seizure. And guess what? He also does IOLs. This is a scleral fixated IOL. So in this case, he did the hat trick on this patient. So a couple other patients, I just love to take photos because they're great. It's really fun to look at them, just to look at it. Look, this patient had decreased vision for 3 days, loss of 2/3 of vision with purple bubbles. Came in saying I had purple bubbles in my vision. Well, I can see your purple bubbles too. I appreciate that. And then of course here we've got that's the first one we saw. We've got that rolling thunder. So going back, I want to give us a couple minutes for questions. So there were a couple questions. I'm going to let you guys put them into the chat as well. I did see some more back around the viral conjunctivitis. So my go-to steroid for viral, you know what? I tend to go loteprednol more often than not. I have better coverage with it now. I like loteprednol just because it's not as irritating to the front surface as far as in comparison to pred. But you know what? A lot of times with this is not my patient who's coming in for ocular surface disease, so I'm not worried. Kind of look at what can I get covered by insurance. So it may be a fluorometholone, it might be a prednisolone acetate, or it might be a loteprednol. Any one of the three, they all are going to do their job. Um, which steroid? Yep, so the same question. The other one, someone did mention that they were told SEI can become scars. Is that wrong? So the question would be, is that wrong? No, maybe not. I never say 100% on anything. There are people where things are different, but I would tell you that my patients, as long as if you have somebody who's got an SE, like a true SEI, and you put a steroid on it, it should resolve, right? If what you're seeing is a scar, whether or not it's truly caused by an SEI, I would argue on that. And if there's maybe a different etiology, because it is literally just an area of inflammation. Um, and I've not seen them scar, but I never say 100%, like I said. Jen, did you see any other questions?
There are a lot. So first of all, that was amazing. Thank you for so much information that made the time fly by. It seemed, I know speaking for an hour and 45 minutes is a lot, but you did it very well. So I want to thank you for kicking off the Ocular Emergency Summit so well and really giving us great cases that are not things that we've only heard about and will never walk into our practice. And I think that's
Hopefully some
so
of these will
helpful.
never, some of those will never walk in
Yes.
anyone's practice, but
A lot will. So let's see.
yeah.
So I was trying to make sure that I don't re-ask a question. If you have questions, you can continue putting those either in the chat or Q&A. Um, Let me go up to the top. There were a couple questions actually. I don't know if you addressed this, but a couple like best practices on taking photos with your phone. How do you do that well? So
Oh, that changes every iteration of phone we have, right? Because they all change. And they all have multiple cameras at this point. I did hold on to my old one that had one camera on it because I loved it so much. Make sure you turn off the auto, like flash, right? We don't want flash. You want to kind of focus with, I do it through the oculars. I used to have something that attached to it and attached to the slit lamp. It doesn't work and mine's gone. If you have one, great. But typically, for the most part, I'm just holding my phone up to the oculars and I'm focusing the main camera through it and turn off. If you have a diffuser for light, like you can flip up the little diffuser, that's really helpful than a slit beam. A slit beam kind of tends to wash it out. Sometimes also actually turning off the light uh, on the slit lamp and turning on the ambient light in the room will actually get you better photos. Kind of depends on what you're trying to take photos of.
perfect. Another follow-up. Can you bill for those photos?
You can, as long as you're putting them into their chart. So I have an app on my phone that is for my clinic that's attached to our EHR. My previous couple clinics have had that. Most of ours do because we have some kind of app on our phone that allows us to access. If you have that, you should be able to actually drop it straight, like it open your camera and drop it straight into the patient's chart. If not, you can still upload it into their chart and you can bill it that way. But yes, it is considered a fundus photo or anterior segment photo, so you can bill for it. Not gonna get a lot because reimbursement, but
Perfect. I am looking for other questions. Any pearls if you live in a rural area? There are some questions about if you send a patient to an ER in a rural area, how do you know that they're getting the right treatment and testing? Do you have any recommendations there?
I do. So with ERs, the best thing that I have found is even if you're not in a rural area, there's always a question of do they know what they're doing? Is there an ophthalmologist or an optometrist that's working with them that they can access? So I tend to send my patients with whatever notes I can, or I have I have fill outable forms that have like my most common diagnoses, and I'll put what I'm thinking. I give my phone number a lot. and say, please call me if you're having questions. If I'm sending somebody for an MRI, I remind the patient that you are going to be checked in and you will become a patient of the ER. I'm not sending you to them for an MRI because that doesn't work. You are actually going to be admitted. But I try to arm them with as much information and then my phone number. If you can, and you're like, hey, I'm like 99% sure this is what's going on, and you know what needs to happen as far as treatment for it, and you know that there's absolutely not an ophthalmologist or an optometrist on staff, send them with what the treatment is.
Perfect. Let me see. I just saw one. Keep the questions coming, please. This is such an awesome opportunity. Oh, I just lost one. Hold on one second. There was one that came in pretty early on. Why do you think we're seeing shingles in younger patients? Anecdotally, this person said our babysitter and my brother had them in their 20s and 30s.
Yep, I did see that question. So, and I think I mentioned it before, but I'll definitely reiterate. So when the working theory is that now that there is a chickenpox vaccination, children who are getting the chickenpox vaccination originally were getting chickenpox, and those of us who were the parents or adults around these kids were getting a secondary exposure, and so it was helping build up our immunity or maintain some functional immune response in our body. And so we weren't getting shingles till we were in our 60s, 70s, and 80s. Now that we don't have that same secondary exposure, we aren't getting that. So, and we're getting shingles earlier. But that's a working theory. We'll see. I mean, those who are getting the vaccination shouldn't ever have shingles, right? So hopefully it just kind of moves out and nobody has to deal with this ever again.
Let's see. Have you used hypochlorous acid spray for viral conjunctivitis instead of betadine?
Yeah, so there's actually a study that looked at that. And I'm trying to remember because I have a whole lecture on that. I'm trying to remember what they came up with, but there was Avanova, the company Avanova was doing a study on it and looking at it for application, and they stopped the study. And I don't remember if it was like a 2020 thing or whatnot. I tend to have my patients cleaning around anyway. I don't know what the protocol would look like on that. If it's like you put the hypochlorous acid in the eye, and do the same thing like you do with the betadine, or what the intent is. But because I had at least seen Avanova was looking at that, I do often talk to them about just cleaning around the eyes with it. So it's a good question.
Perfect. This is a great question. What two eye drops would be essential to have in office for acute angle closure?
I would say if you can have a combo, like a dorzolamide timolol or a brimonidine timolol, um, and then also, I don't know, if you can have a brimonidine, a timolol, and a dorzolamide, have those in there. And whether that's a combination or not, however, I mean, we can get them generically now. In my sending homes, I hate generics, but whatever. The whole point is we're just trying to get that down. So if you can have something like that in office, that's what I would do.
Perfect.
Alpha-GAN is technically, I think, the only aqueous suppressant. So you definitely, but if you have all three of those in there, whether combination or not, you're going to have suppressant and increased outflow.
Going back to the losartan treatment you mentioned, there's quite a few questions about that. That was pretty interesting.
Yeah.
Is that the first question is that from a special compounding pharmacy, or where do you get that?
Yeah. And then somebody else also asked, is there a way to reduce stromal scarring post-herpetic infection? Yes, losartan. Steroids helps too, right? But when you've gone beyond that and you're looking at trying to decrease scarring without going surgical, losartan has been working in my practice really well. I want more experience. I'm continuing to have patients be referred into me for it. But it is through a special compounding pharmacy. So I found the studies. I have a really great compounding pharmacy here called Pencall, that I work with. The head pharmacist, Miles, he and I are on the phone. I send him studies and I'm like, hey, can we do this? And this literally is what happened. I said, hey, can you do this? And what would the cost be? The other, there is a pharmacy. So O'Brien's a lot of people use O'Brien's because they'll ship nationally. I think they're out of Kansas, if I remember correctly. But they also have a topical compounded losartan for ophthalmic use as well. But don't hesitate. If you want the information, I can always send people the study. If you're interested in trying to talk with your local compounding pharmacy to try to do that, don't hesitate. Talk with them. A lot of times they're open to conversation.
What are your recommendations for stopping a cycloplegic for a patient with iritis? Should the anterior chamber be completely clear? Or what are your best tips there?
So I tend to go based on how is the patient feeling, and what am I seeing as far as the anterior chamber reaction before I start decrease or like getting rid of it. If I see that even if there's still a little bit of reaction, if I've got like trace, I'm not worried, right? A rare cell or trace, I'm not worried. I'll go ahead and stop it because it's going to help improve like light sensitivity and other things that they're probably having side effects from, decreased vision, which they like to complain about. If the pain is gone and I'm seeing just trace, maybe cell, I'm fine with taking it and getting rid of it.
Do you know what happened to osmoglin for acute angle closure treatment?
Do not. Do not. And I know exactly what you're talking about, but it's a really good question because I have not seen that in about 10 years. So I unfortunately don't have an answer on that one.
Perfect. I think I'm going through and I think we got to everything. If there's any last minute questions, please go ahead and put them in. I'm looking at both, but I think we got through. There's a lot of great comments. So I know you don't always get to see those, but a lot of great comments. A couple people wrote, I have no question, but thank you for the presentation. That was great. So I know
Good.
I don't always read those, but they're sprinkled in there as well. So that was fantastic and a great review. And I know that you are so welcoming with your email address. So if there are questions that you
Yes.
didn't answer or you want to follow up or would like any of those studies, I'm sure if somebody emailed you that they would be able to get that from you.
Absolutely.
So
Perfect.
let's see. Well, with that, I want to thank you. The QR code is up here. So if you have your OE Tracker app, go ahead and scan that QR code now. You can also find all the survey links in the chat. A reminder, we are not done for the day though. That is half of our day. So we're going to take a quick break so that everyone can go grab some lunch. They can go get some a snack, take some time, and we will be back here at 1 o'clock Eastern, which is 10 a.m. Pacific, correct? Yes, I have it all written down. So for our next session, so everyone can take a stretch break. Make sure you have your coffee for the afternoon. But Dr. Kenning, thank you again for being here. You're always such a valued, wonderful contributor for WooU, and we're really happy to have you for this summit this weekend.
Thank you so much for having me. This was wonderful.
Okay, everyone take your break, and then we will see you back in about 13 minutes. All right, everybody, welcome back. I hope everyone had a quick break and is ready to power on through the next 2 hours to round out our Ocular Emergency Summit Day 1 at Wu University. So we are back with our second presentation, Urgency of Emergency, 3rd, 4th, 6th, and 7th nerve palsies with Dr. Tamara Petrosian.
All right. Hi, everyone. So I'm just going to put up my financial disclosures, but nothing we're going to be talking about has anything to do with any of my financial disclosures, and everything's been mitigated. So we are going to be talking about urgency or emergency and trying to figure out which way to go for our 3rd, 6th, 4th, 6th, and 7th nerve palsies. For more information, these two textbooks are wonderful in terms of their illustrations as well as just explaining everything by breaking everything down. So wonderful references and resources. For today, we're going to be talking about anatomy and physiology as well as the function of the nerves. And then we're going to talk about the more common dysfunctions that you're going to see in these cranial nerves. We're really not going to be talking about the actual nuclear, the ones that generate inside of the brainstem, because those are usually very, very severe and have a lot of other side effects that we are usually going to see in things like the emergency room. So those are not going to be walking into your office. And we're really not going to be touching on treatment and management today. We really want to delve into how to differentiate if it's an urgency or an emergency for these patients. So let's just start off talking about cranial nerves in general. We have 12 of them, and they directly emerge from the brain, versus our spinal nerves, which are the ones that are going to be emerging from the spinal cord, right? The cranial nerves are going to relay information between your brain and the rest of your body. And we have the first and the second cranial nerves, which are going to both originate as well as emerge directly from the cerebrum itself. And then the rest of them, the other 10, are going to originate and emerge from the brainstem. And those are going to be the ones that we're going to be talking about. And in case you were wondering in terms of the numbering, how it goes from 1 to 12, the numbering is going to be based on the order in which they both emerge from the brain. And it's going to go from front to back as well as centrally to laterally. So that's how the naming of the nerves or the numbering came about. The cranial nerves are considered part of the peripheral nervous system, again, except for that first and second, because they do come out of the cerebrum itself. And then we have the central versus the peripheral nervous system. So definitionally, central nervous system is going to consist of your cerebrum, so that's your white matter, your gray matter, the brainstem, the cerebellum, as well as your spinal cord. And these are going to integrate information that's received from the body and then coordinate and influence activities of all of your different body parts. And then our peripheral nervous system is the thing that's going to connect our central nervous system to all of your organs, to all of your limbs. And the peripheral system is going to be the one that's going to relay information between the brain and the spinal cord and the rest of the body. So for me, I'm a very visual person. I like to figure out where I am visually. So we have a nice illustration of the majority of the nerves that we're going to be talking about. So here's the first cranial nerve. Just so you get yourself situated, we have the pituitary sitting right here, our optic one right there, and then we have the third, the fourth, the fifth, and 6, 7, and 8 kind of hang out all together right over here. And then if we plop this into the actual skull, we have our pons over here, our midbrain over here. We have our cavernous sinus, which is a very important anatomical structure, which we're going to be talking about a lot. The superior orbital fissure, where all of the nerves come into the orbital area. And then we have our third, our fourth, and then our sixth, as well as our fifth over here. So this gives you a really good visual as to where we are inside of the skull. Like I said, the cavernous sinus is going to be a very important piece of anatomy for us to kind of recall if we go back to our anatomy and physiology days. So the cavernous sinus is going to be sitting on either side of the sella turcica. It is a venous sinus. So it is an intracranial venous channel, right? So all a sinus is just a really, really big vein. So it's a venous channel that's going to pretty much drain all of the blood from the eye, from the brain, and from all of your meninges to the internal jugular vein. And it's also going to facilitate the entrance or the passage of cranial nerve 3, cranial nerve 4, the first and second portions of cranial nerve 5, cranial nerve 6, as well as the cavernous part of the internal carotid artery, which has the sympathetic trunk wrapped around it. And if you remember, again, back to anatomy and physiology, your third cranial nerve also holds your parasympathetics. So we have the third, the fourth, the fifth, the sixth, as well as your parasympathetics and your sympathetics running inside of this venous sinus. So it's going to be a really important piece of anatomy for us to remember. If we take a slice through it and you're looking at somebody, this the cavernous sinus is organized in terms of how the nerves kind of come out and then also enter into your orbit. So we have the third, we have the fourth, we have the first and second part of the fifth, and then we have the sixth cranial nerve sitting right there, all nice and neat. So again, cavernous sinus sits over here. the nerves, once they pass through that cavernous sinus, they actually enter into the orbit through the superior orbital fissure. Again, we have one on each side, and you can see that fissure right over here. So again, just anatomy for us to review. Once the nerves go through the superior orbital fissure, then some of them will go through the annulus of Zinn. So if we recall, the annulus of Zinn is this ring of just fibrous tissue that's going to surround the optic nerve at the apex of the orbit. And it is going to be the common origin of your extraocular muscles, all of them except for your inferior oblique. The inferior oblique is going to originate from the lateral border of your lacrimal fossa, but everything else is going to originate from there. This is a really cool video. I hope it plays that I found. I'll play it twice because it really is very cool to see all of the nerves and fibers and the annulus of Zinn kind of nicely put together in a video here. So let me play that twice because it's a very pretty video that, let me see if I can get that one more time for you guys. It just shows where all of the muscles kind of go in and they meet the actual orbit. And we're going to be talking about the innervation of all of these muscles. All right. So let's start off with the third cranial nerve, right? So we are sitting right over here and coming into the orbits right over here. So again, we're going to do third, fourth. We're not going to do fifth today, sixth and seventh for today. So our third cranial nerve is going to originate at the midbrain. It is going to go to the lateral side of the posterior communicating artery, which is going to be very important because if we have an aneurysm there, it's going to nick our third nerve. It is going to go through the cavernous sinus, then it's going to go into the superior orbital fissure, and then it's going to enter the orbit. Once it enters the orbit, it's going to split into its superior division, and that's going to go to innervate your levator palpebrae as well as your superior rectus, and then your inferior division is going to go and have your parasympathetics for constriction of the pupil for accommodation, as well as your inferior rectus, medial rectus, and inferior oblique. So it pretty much controls all of the muscles aside from your superior oblique and your lateral rectus, right? So it has a lot of things that it's controlling, from your pupil to your lid to your extraocular muscles. In terms of the pupil with the parasympathetic, so if we recall the pupillary pathway or the light pathway, when the light goes in, it goes into the eye, it goes through, it bifurcates, it goes to the pretectal nucleus, it bifurcates again, and then those efferent fibers at that point are going to move forward. They're going to meet up with the parasympathetic fibers, and they are going to innervate your pupil for constriction as well as for accommodation. The constriction component is only 3%. The majority of the innervation is actually going to go to the ciliary body for accommodation. But you have light shining into one eye. It's going to cause equal and bilateral constriction in both of the eyes because of all of that bifurcation that's happening in the brain part. If we remember the location of the parasympathetic fibers, your parasympathetic fibers within the third cranial nerve are going to sit on the superior medial portion of the nerve. So if we take a look over here, right, this is the third cranial nerve, the parasympathetic fibers are sitting right over here. So if we have a lesion that is stemming from over here, right, from outside of the nerve, and it's growing, so either say there's a hemorrhage or there's an aneurysm of some kind, it's going to start growing and growing, and it's going to nick those peripheral pupillary fibers first, and so you're much more likely to get a nick of the function of the parasympathetic pupillary fibers, meaning your pupil is not going to constrict, meaning you're going to get a dilated pupil. If you, on the other hand, have, for example, an ischemic third nerve, right? So your blood vessels that give oxygen to the nerve are going to sit in the middle of the nerve. So if you have ischemia that is causing a third nerve palsy, then it's going to be much less likely to nick or affect these pupillary fibers, or it'll happen much later on in the process. So if we have something like a trauma, or if we have something like a lesion, or if we have an aneurysm, then our pupillary fibers are much more likely to get affected first in a third nerve palsy. Versus if we have something ischemic, then it's going to be much more likely to be a pupil sparing, meaning you have a third nerve palsy, but your pupil is not involved. So you don't have that dilated pupil. Very important to remember that if you have an incomplete third nerve palsy, meaning some of the muscles that are controlled by the third nerve are still functional, some are not, some are still functional, then you absolutely cannot rule out pupillary involvement, because it might be an aneurysm that is still evolving and is still forming, and you're just catching it in the very beginnings of things. And so that becomes an emergency. So any type of incomplete third nerve, even if there's no pupillary involvement, that becomes an emergency. So what are the patients going to come in looking like? We're going to get diagonal diplopia at distance and at near. We're going to have the eye that's going to be down and out. We're going to have a very severe ptosis. And then we're going to have something reversing called reversing hypertropia, which we'll talk about in a second. So again, we're going to have an eye that's down and it's out. You're going to get exotropia, worse on contralateral gaze, because your medial rectus is affected, and so you can't adduct. Because your elevators are affected, the fellow eye is going to be hyper whenever you try to look up. But because your depressors are affected, the involved eye that has the third nerve palsy is then going to become hyper when you're looking down. So that's the reversing hypertropia that we look for in a third nerve palsy. So when you're looking up, the fellow eye is going to be hyper. When you're looking down, the involved eye is going to be hyper. So the hypertropia is going to change depending on if they're looking up or down. And that is pretty much a clinical sign of a third nerve palsy. You're going to get a very severe ptosis because your levator is involved. And again, not always, but your pupil can be dilated. In terms of etiology, a lot of times, especially for the adults, we're really not going to find out an actual cause. The secondary cause is going to be aneurysmal, followed by ischemic or vasculopathic, and then traumatic. If we're looking at the pediatric population, congenital is going to be our primary go-to, followed by trauma, because kids get a lot of head trauma. And then we're looking at things like inflammatory, neoplasmic, before we start looking at things like ischemic or aneurysmal. So we're going to break things down. This is for all of them in terms of subarachnoid lesions. So that's the path going from the brain to the eye. And then we're going to talk about lesions in the cavernous sinus, and then lesions of the actual local muscle itself. So with the third nerve, subarachnoid lesions, that's usually going to be your aneurysm. With an aneurysm, you might have no other neurological symptoms at all, but if you have an aneurysm that is actually ruptured, your patient is going to come in with very severe headaches, a stiff neck, a lot of discomfort, a lot of other neurological signs. So those patients are likely going to be ending up in the emergency room on their own, because they're going to come in with a very severe headache. But if you ever have someone coming in with a third nerve palsy, no matter if the pupil is involved or not, to be honest with you, and they have very severe headaches and they have a stiff neck, that gets a 911 call and heads over to the emergency room right away. Again, remember that usually, if the pupil is not involved, it's going to be an ischemic third nerve, but that's only true in 86% of the cases. It's not a 100% guarantee on the initial presentation, because things might still be evolving and forming. You might still be seeing the very early signs of the third nerve. So make sure to watch for pupillary signs very, very carefully, especially in that first week. So aside from an aneurysm, we can also have trauma, right? So if we have a very severe head trauma, especially in our elderly patients, especially in our patients that have a history of alcohol abuse, where their brains actually shrink and they pull out all of the blood vessels in the brain a little bit tauter. So any type of trauma can cause bleeding in the brain much more easily. If we get a subarachnoid hemorrhage in the brain, the bleed brain, if it's severe enough and if it's happening long enough and it causes enough actual accumulation of blood, can act as a mass. So it's as if there's a tumor growing inside of the brain. Once this subarachnoid lesion or hemorrhage gets big enough, it can actually start shifting things over in the brain, eventually causing something called an uncal herniation. So an uncal herniation is when the temporal lobe actually herniates over and shifts over, and it will nick that third nerve. So a lot of times when we have an unconscious patient coming to the emergency room, and you'll see on the shows they'll do the pupillary test. What they're looking for is for a blown pupil. They're looking to see if there's a third nerve palsy in this unconscious patient with a blown pupil, because if there is, then it's a very significant sign that the patient might be having a hemorrhage or a bleed due to and causing an uncal herniation. And so they know that the patient needs to have that blood evacuated as soon as possible before even more trauma starts to happen. So that's why they're kind of looking for that pupillary reaction. When we talk about the cavernous sinus, the big thing we're going to look for is a cavernous sinus fistula. So a fistula at large, definitionally, is an abnormal connection between two hollow spaces. So when we're talking about the cavernous sinus, a cavernous sinus fistula is an abnormal connection between specifically the cavernous sinus and the internal carotid artery. So for whatever reason, we start getting congestion in the cavernous sinus, which is then going to prevent blood from draining out of the eye. And so blood that's supposed to be draining out of the superior and inferior ophthalmic vein can't drain out because there's something blocking it. And so there's blockage of all this blood inside of the eye, unable to get out. And it can be due to a lot of different things, like an aneurysm in that location, a hemorrhage preventing blood from coming out, any type of growth, neoplasm, something that is causing inflammation at the level of the orbital apex. There could be an infection in a nearby sinus preventing outflow. There could be some form of trauma. Again, remember that your cavernous sinus is going to hold your third, your fourth, the first two branches of your fifth, your sixth, as well as your parasympathetics and your sympathetics. So if we have any type of trauma or congestion or any type of dysfunction in this area, you're going to have very, very significant side effects in terms of your cranial nerves, ocular motility, as well as your pupillary function. Let's see. So you are usually going to have, I mean, this is an extremely severe case, but because you have so many things going through your cavernous sinus, you are going to be looking for something that's complicated, right? That includes several different cranial nerves, as well as pupillary dysfunction. It might be the pupil is unable to constrict. It might be it's unable to dilate, depending on which fibers are being nicked first. But you're also going to be looking for a difference in the amount of congestion of your conjunctival vasculature. Because the blood flow is unable to drain out, your conj is going to be extremely chemotic, and it's going to be very, very tortuous, and the vasculature is going to be a lot thicker and more swollen. If you have a very severe blockage, then you can have bilateral signs, but it's usually going to be worse in one eye versus the other. Okay, so anytime you have something complicated where the vessels of your conjunctiva look tortuous and look engorged, you're going to think cavernous sinus. And then we have our orbital local lesions, right? So those could be from a trauma, a growth, an infection, inflammation. Again, remember we have two different fibers or branches of the third nerve. Once it actually goes through the cavernous sinus and enters into the superior orbital fissure. So our superior fibers are only going to innervate the superior rectus and our levator. And then our inferior fibers are going to hold our parasympathetics, as well as our inferior medial recti and our inferior oblique. So if you have a local orbital lesion, you can get an incomplete third nerve palsy. So if you have an incomplete palsy, you have to try to differentiate and monitor over time to look for progression, as well as your history, right? So if someone comes in and says that they just recently had a blowout fracture, or they had some kind of trauma to the area, it's much more likely to be an orbital lesion. But you want to, for all of your incomplete third nerves, take a very, very close look and monitor them very closely in the early days to make sure that it is not a lesion that is still forming and progressing and getting worse. One thing with our third cranial nerves that can happen months after the resolution is something called aberrant regeneration. So when you have damage to the third cranial nerve and you have recovery of that damage, there can actually be misdirected or aberrant regeneration of the nerve fibers that control the different parts of the muscle, as well as areas that are innervated, such as the levator. So for example, when we look down or when we adduct, if there's aberrant regeneration, we might get elevation of the upper eyelid at the same time. Or when we adduct, we might get constriction of the pupil in that eye. It's very important to remember that an ischemic third nerve palsy is not going to cause aberrant regeneration. So if you have a third nerve palsy and your diagnosis is ischemic, diabetic, hypertensive, whatever it might be, and say 6 months down the line, you start noticing aberrant regeneration, you have to revisit your diagnosis, because ischemic disease that causes a third nerve palsy, once resolved, is not going to give you aberrant regeneration. So if you're seeing aberrant regeneration, that is not an ischemic third nerve palsy, and you need to revisit your diagnosis. So let's take a look at a complete third nerve palsy. So we have a severe ptosis, we have an eye that is down and it's out, and this is the reversing hypertropia that we talked about. So when the patient is looking up, the contralateral eye is going to be hyper because your affected eye can't elevate. But when the patient is looking down, your ipsilateral eye is going to be hyper because the eye can't depress, right? So you have reversing hypertropia. This is a classic sign. So a lot of people, when there's an incomplete third nerve and they're not sure, it's not a classic down and out, or not sure what's going on, this reversing hypertropia is going to show up even with an incomplete third the majority of the time. So this is a really good sign to look for if you're trying to figure out if it's a third nerve or not. So we talked about anatomy and where where things stand. So is it an urgency or is it an emergency? If we have an isolated, complete ischemic, right? So it's an older patient with known diabetes, hypertension that's not been well controlled. That's more of an urgency, right? So we want to talk to their primary care. We want to talk to their endocrinologist. In the beginning days, if we're not very sure, we might want to consult with a neurologist and make sure that there's nothing else going on and that it really is an ischemic third. But once we solidify that it's an ischemic third, we're really not too worried about that. It's not an emergency that needs to head to the hospital right away. So if the pupil is spared, they have an atherosclerotic risk factor that has been very poorly controlled, if they had it for a long time, and it's a complete palsy, it's not an incomplete third, then it's an urgency. They still need to go in, they need to get their blood work done. They need to, if they're older, we need to evaluate for GCA. But if they have a history of the smoking and the high cholesterol and they're older, then it's more likely an ischemic disease. So we're just going to very carefully monitor them for any type of pupillary involvement, especially in that first week. And then we're going to look for any aberrant regeneration. Again, aberrant regeneration, it was not an ischemic cause. If we have, let's see. Okay, so our microvascular third, so anything atherosclerotic, is going to usually resolve if everything systemically starts to become regulated and controlled. The sugar goes down, the cholesterol goes down, the blood pressure goes down. Usually in about 3 months or so, they're going to get resolution of their third nerve. If you're not exactly sure, there's a lot of variability going on, you might want to do a serological or a tensilon test to rule out for myasthenia gravis if there's more of a variability in the pattern, because it can mimic. It's one of those great mimickers. With myasthenia, again, there is no pain. Usually a third nerve is not going to cause pain unless it's aneurysmal. But with myasthenia, there's never going to be pain. And if the patient is over 65 years old and you're doing blood work anyway, you might want to do a panel for GCA. If you have an incomplete third nerve, that's an emergency, right? Because an incomplete third nerve could be an evolving third nerve. And so that is an immediate, if you have a contact in the hospital for a neuro-ophthalmologist or a neurologist and they can be seen the same day, that's what you do. If not, then you just call 911 and they go to the basic emergency room. The neuro department will know what to do with them a little bit better. They'll get fast tracked a little bit faster for all of their scans and images and treatment. If you don't have a contact, then they just go to the emergency room. Again, any incomplete palsy, especially if there's a headache, if there's a stiff neck, we get 911 called right away. If there is pupil involvement, right? So before we said complete, no pupil involvement, known cardiovascular risk factors that are out of control, more likely arthrosclerotic. If there is any type of pupillary involvement, it doesn't matter if it is complete, incomplete, what's going on, that's a 911 call, that's a referral to the emergency room right away because we're trying to make sure that there is no aneurysm that is causing that third nerve palsy, which could rupture at any moment and be life-threatening. If we have a complicated third nerve, so anything complicated means you have a third nerve palsy or whatever palsy, plus some other neurological symptoms. So it's a third and a fourth, or it's a third with a headache, or it's a third with nausea, or it's a third with loss of balance, or anything neurological going on. And this is true for any cranial nerve palsy. So two cranial nerve palsies together or any type of other neurological sign, that is an immediate referral to either neurology or ER because we are trying to make sure that there is no sign of any type of a stroke to the brainstem. So anything complicated, we send that to the emergency room right away. In terms of our differentials, there are a lot of things that can mimic a third nerve palsy or look like a third nerve palsy. So we'll go through some of the more common differentials. Graves' disease. This is an autoimmune disorder that's going to cause motility deficits because we have swelling of the fibers around the extraocular muscles, and it's going to be usually your medial rectus that's going to be involved. You're going to have positive force sections, and you're usually going to have other orbital and systemic signs with this. But that can mimic an incomplete third nerve, for example. Myasthenia gravis, again, that can mimic pretty much everything that we're going to be talking about. This is an autoimmune disease that's going to affect the neuromuscular junction. It's going to cause weakness to the muscles, which is going to be worse when the patient is fatigued, and there's going to be a lot of variability in the presentation. And again, it can mimic any cranial nerve palsy, but it will usually mimic more so a sixth nerve palsy rather than a third. And ptosis is a frequent finding. That's why sometimes it gets confused with a third nerve. Orbital meiosis, this is an idiopathic inflammation of the muscles in the orbit, and you're going to get a lot of pain, you're going to get restrictive myopathy, and you can also get proptosis with the orbital meiosis. Usually going to be unilateral, there's going to be pain, usually going to come on very quickly without any kind of prodromes. And then multiple sclerosis. So this is a progressive demyelinating autoimmune disorder of the nervous system. It can mimic pretty much and cause any type of ocular motor dysfunction that it wants to. But again, with MS, you're usually going to have other visual or neurological signs. Lyme disease is another one of those great masqueraders. It is a tick-transmitted multisystem inflammatory disease caused by the spirochete, and if we have Lyme-induced meningitis, that can cause isolated or multiple cranial nerve palsies in our patients. And then last but not least, I believe, is either concussion or brain trauma. So if we have any type of damage or swelling or shearing of our cranial nerves or the muscles themselves, that can mimic any and all cranial nerve palsies. And this can happen in both direct, where the head actually gets hit, as well as indirect trauma, meaning the head doesn't actually get hit. So you have a really bad fall where your head doesn't actually hit the pavement, but you're, say, running really, really fast, and then all of a sudden you fall. What happens inside of your skull, your brain inside of your skull is similar to having jello inside of a tub. The brain isn't really tethered down to anything. So imagine taking a tub of jello and just shaking it really vigorously. When you're moving really fast and all of a sudden you stop, what happens is your brain is still going even though your body or your skull has stopped. So your brain smacks into the front of your skull, that's your coup, and then it smacks to the back of the skull, that's your counter coup, and that causes a lot of swelling and twisting and turning of your nerve fibers inside of the brain. So you don't have to have actual direct contact or a hit to the head to cause damage. And if you already have a weakened binocular system or decompensated system, then it can just be that extra thing that causes you to start having diplopia or start getting a strabismus. Usually a fourth nerve palsy is much more likely to be caused by something like a concussion because, as we'll talk about next, the fourth nerve is extremely thin and very, very long. It has a very long pathway inside of the brain, but you can still get a third or a sixth nerve palsy with head trauma. All right, any questions on our third nerve before we move on to the fourth? I can't see you guys.
I'll do the question and answer at the end if you'd like.
Okay, that sounds great. Okay.
So everyone can keep putting their questions in, and then we'll go through them at the end.
Okay, sounds good. All right, so we did our third. Let's move on to our fourth. So our fourth nerve is really cool because it is the only cranial nerve that is actually going to move backwards, move posteriorly, then it's going to actually cross over. It's going to move to the contralateral side, and then it's going to take this very long subarachnoid path into the cavernous sinus, superior orbital fissure, and go on to innervate the contralateral superior oblique muscle. Right, so it's very, very thin, it's very, very long, and it's the only one to actually come out from the back of your brainstem. Yep, we said all that. I love this picture because it really shows very nicely. This is where the fourth nerve actually comes out, right, in the back of the brainstem. And there's this little tiny, well, here, over here, there's this little tiny bony ridge that sits pretty much right where the fourth nerve exits dorsally. And so any type of trauma to the head or to the brain that's going to cause that shaking of the brain can cause the sixth cranial nerve to literally hit up against this bony ridge over here. So it's very, very easy for us to get trauma to the sixth cranial nerve, not to mention the fact that it's very, very thin and it has the longest path through the subarachnoid space. There's a lot of different areas as it's traveling through the subarachnoid space for it to get damaged. So very, very easily bruised from very, very mild trauma. And because it kind of comes out in the same place, depending on how severe the trauma is, you might get either a unilateral or very easily, if it hits right up on this bony ridge where the fourth cranial nerve comes out, get a bilateral fourth cranial nerve palsy. So our fourth cranial nerve is going to innervate the superior oblique muscle, and our superior oblique is going to have two main functions. So when your eye is abducted, it's going to be a pure intorter. And when your eye is adducted, it's going to be a pure depressor. So if we have a palsy to our superior oblique, then we are going to have tropia or diplopia that is going to be worse on adduction and when the patient's looking down. So it's easy to remember that with a fourth nerve palsy, the patient's going to have problems reading or looking at their phone, right? Because they're going to have problems bringing their eye down when they're adducted. So when they're trying to look down as they're converged, looking at the phone, trying to read. They are going to come in with the head tilted to the opposite side. So if it's a right superior oblique palsy, their head is going to be tilted to the left side to try to kind of negate or counteract the palsy that they're having. And if you're checking with a Maddox rod, they're going to be X-cyclotorted. As we said, you can get a unilateral or bilateral fourth nerve. One of the quickest and easiest ways to confirm if it's a unilateral or bilateral is to do an evaluation of how much X-cyclotorsion there is. If you have more than about 15 degrees of X-cyclotorsion, then you're much more likely to be having a fourth cranial nerve palsy. So if we have a patient coming in, a lot of times looking straight ahead or looking to the same side, you're not really going to realize that there's any problems whatsoever, especially people are very smart. And so if they have diplopia and they tilt their head over to the side and they no longer have diplopia, they'll usually come in looking like that. When you're going to start seeing that large strabismus or a funky EOM is going to be when they try to adduct or look down, right? So that's when you're going to see the eye shoot up or an inability to depress their eye when they are adducting. So when they're trying to read or look at their phone. A lot of people get nervous about doing the Parks 3-step because there's a lot of steps to follow and things to draw out. So I came up with my own version, I guess, of the Parks 3-step, if you will. So all you really need to remember is right, right, or left, left. So if a patient comes in and you're doing EOMs and their EOMs look funky, right? And you're thinking that there might be a fourth nerve palsy and you want to do a Parks 3-step. What you're going to do is you're going to either do cover test, or honestly, it's a lot easier just to do the modified Thornton, which is this guy right over here. You have the red lens with the grids on it that produces a vertical line when you're looking at a pen light, and you're going to have a chart that has distinctions of in prism diopters of how much deviation there is. So the patient, there's a light that's shining behind the card right over here. The patient is looking at the light and they have this this little red occluder holding up. So with one eye, they're going to see the white light. With the other eye, they're going to see a red line. And what you're going to do is just ask them what number is the line going through, and is it on the right side or on the left side? And that'll tell you how much of a strabismus or a deviation there is between the two eyes. And then you're going to have them look in different positions of gaze and see if there's a difference in how much of a strabismus there is, depending on where they're looking, right? So if you're looking and you're suspecting the right eye, for example, what you have to remember is right, right. So their hyper or their strabismus is going to be worse in the right eye when they're looking straight ahead. The hyper is going to be worse when they look to the left. And the hyper is going to be worse when they tilt their head to the right. So right, right. And again, you can either do cover tests to see if the strabismus got worse, or you could do the modified Thornton. If you feel like the left eye is wonky and you're suspecting a left fourth nerve palsy, then it's going to be left, left. The strabismus is going to be worse in the left eye on primary gaze. It's going to get worse when they look to the right, and it's going to be worse when they tilt their head to the left, right? So for example, we have a patient with a left superior oblique that we're suspecting. So we have them look to the right, we have them look to the left. It's worse when they look to the right. And then we have them tilt their head to the right. Oh, where'd we go? And to the left, and it's worse when they tilt their head to the left. So left, right, left. It's a left superior oblique palsy. I hope that's helpful to you guys, because a lot of people get very stressed out about the Part 3 step. In terms of our fourth nerve, again, with most of these undetermined, we never really find a cause, is what's going to be the primary cause for most of these. But if we pass that, then obviously traumatic is going to be our go-to, especially for our elderly patients or the young adults, our young adults. For our real elderly patients, then we are going to be looking more at ischemic factors. And then for our pediatric patients, the trauma and congenital is going to be our primary etiologies. How do you differentiate if it is an acquired versus a congenital fourth nerve? Let me just double check my time. Okay, we're good. One of the best things that you can do is do a FAT scan. So family album tomography, just meaning look at some old pictures, right? A lot of times if it's a congenital palsy, especially if it's not severe, people might have had a head tilt for years and years since childhood, and they never picked up on it, and nobody else around them picked up on it. So you'll be surprised how many times you'll have people bring in, their family photos or show photos on their phone from, a decade ago, and they'll always have this tiny little head tilt over to the side that nobody ever picked up on. They just thought that that was their regular posture. So you're going to look for a head tilt to the contralateral side of where their palsy is. So if it's a right palsy, they're going to be always tilting their head over to the left side. And that's going to be one of your biggest kind of indications that it is a congenital or a long-standing palsy. Because when they bring the head straight, when they're not compensating, then they're going to be diplopic. The other thing to tell you that it is a congenital or very long-standing fourth nerve palsy is your vertical ranges. So we usually do not do vertical ranges on our patients, especially in the primary care clinic. But in this case, this is where you do want to do those vertical ranges. So if you have vertical ranges greater than about 6 prism diopters, which usually they should be 2, 3, 4 prism diopters until the patient says that they're diplopic vertically, then that is an indication that that is a very long-standing or congenital fourth nerve palsy. One thing with fourth nerve palsies is there are a lot of patients, elderly patients, where, and why we say to do the FAT scan and the vertical fusion ranges, where they might have a weak fourth nerve, meaning their fourth nerve or their fusion is kind of weak, but they've been sick, they're older, there's an immune problem, there's been an infection, or even a mild head trauma, a concussion, that can then cause compensation of a congenital palsy that they've had for a really long time, that they've just had a robust binocular system, and they've been able to fuse those two images even though they've had this congenital mild fourth nerve palsy. And now all of a sudden they're tired, they're sick, their immune system is out of whack, they had a mild head trauma. All of a sudden they are no longer able to compensate using their binocular system for this mild palsy. And so they might present with a sudden onset fourth nerve. But you do the FAT scan, you do the vertical fusion ranges, and you find that they have extended vertical fusion ranges. That puts your mind at ease significantly that this is something that's been going on for a long time, and they're just no longer able to compensate for using their binocular system. So if we have an isolated congenital fourth cranial nerve, then that's just something that we're going to monitor. We're going to manage the diplopia as much as we can. Things are isolated, meaning there's no other neurological or cranial nerve signs. Things are stable, not progressing. It's been there for a long time. They've had the head tilt. They have increased fusional ranges. There's really no further evaluation that is necessary. With congenital fourth nerve palsies, sorry, you can do, depending on, the severity of it, you can do prismatic corrections, which don't usually work too well for these, but vision therapy, partial occlusion, where you put some duct tape or some, let's say, clear nail polish just in the area where the diplopia occurs so that you prevent diplopia from occurring. And very, very rarely, I don't think I've ever sent a fourth nerve out for a surgery. But if the patient has a very severe fourth nerve and is extremely symptomatic, then we can consider a surgical consult. But those are usually non-surgical management. If we have an acute fourth nerve in an older adult, then that's more of an urgency for blood work, right? So those are usually going to be due to an arthrosclerotic, due to an ischemic factor. So we're looking in the vasculopathic type of etiology. Again, old ESR for GCA, just in case, even if they don't have symptoms. And then we're going to do a tensilon test or serological testing for myasthenia gravis. Again, just in case, because those could be mimickers. So again, as long as they have an ischemic factor, it's isolated, and it's not progressive, then we really don't need to do neuroimaging in these patients. If we have an acute fourth nerve in a young adult or a pediatric patient, then that's an urgency for imaging as well as for blood work. So it doesn't have to come in, tomorrow, but within a week or two, they should be getting blood work and imaging done. With our younger patients without any type of vasculopathic risk factors and absolutely no history of any type of head trauma, then we want to get neuroimaging done within the next week or two. As we said with our third nerves, these patients should be monitored for progression, because if things are getting worse, then that means there's something else going on. So you want to be monitoring these patients either yourself or co-manage monitoring with a neurologist. If there's any additional signs, so it's not isolated, it's a complex case. If there's any signs of progression whatsoever, then we need to do neuroimaging and we need a neuro eval. In terms of our differentials, there's, again, a plethora of differentials, anything from a decompensated phoria to atrophy of the pulley, to skew deviations, any type of thyroid dysfunction, vitamin deficiency. But one of the more common ones that might be confused with a fourth nerve is something called Brown syndrome. So Brown syndrome can either be congenital, usually, or it can be acquired. It's also known as superior oblique tendon sheath syndrome, right? That's a mouthful. And this is a mechanical problem. So your superior oblique muscle or tendon is going to be unable to freely go through the pulley system. Where's our pulley? So our superior oblique is going to go through this pulley before it actually goes and attaches to the eyeball. So if there is a mechanical problem with the pulley where the tendon is unable to freely pass through and move through smoothly the trochlea, that little hole that it passes through, then it's going to get tethered or held down by that tight junction, giving it restriction of upgaze on adduction and giving you the appearance of a fourth nerve palsy. All right, let's move on to our sixth. So again, if you have any questions, just put them into the chat for us. So we're going to bypass our fifth, and we're going to head over to our sixth nerve. So I just want to mention that if you take a look, our third or fourth or fifth, they're kind of far apart from each other, right? But if you look over here, our 6, 7, and 8 are very close to each other, and they're all kind of coming out of the same place. I know it makes it seem like they're further apart in this picture, but everything is really kind of close together. So once we get in this area right here, it's much more common to get a complicated palsy, meaning there's other cranial nerves involved, than it is when you're up here and there's a lot more room and you need a lot more area of the brain to be damaged or impacted before you get a complicated case. So with our sixth nerve, The 6 nucleus is going to come out in the pons where the other 2 were in the midbrain. It's going to move anteriorly. It's actually going to go down, kind of sink down first in the subarachnoid space, and then it's going to go over the clivus. The clivus is that like flat, long bone, which we'll show. And it is going to go into the center of the cavernous sinus, into the superior orbital fissure. And then it is going to go on to innervate our lateral rectus for abduction, right? Abduction of the eye. That's its only function. So signs and symptoms, we're going to get horizontal esotropia in primary gaze with a deficit in abduction, right? So we're going to get a horizontal ESO, not really too many problems with adduction, but we're going to get an inability to abduct. So a little bit of an ESO on primary gaze, no real issues when we're trying to look to the same side, but unable to look to the opposite side, I'm sorry, but unable to look to the same side, so unable to abduct. And then here, because usually when we're looking at near, we're converging, and convergence isn't really affected here. We're able to adduct. We're going to get worse diplopia at distance than we are at near. In terms of causes, if we're looking at our pediatric population, this is where we start to think of things like neoplasm or any type of infection or inflammation, as well as trauma. And then when we get to our elderly population, then our ischemic and vasculopathic and then infectious come into play. So if we have a subarachnoid lesion, right? So again, remember that this area here, everything is coming out pretty close together. So the cerebellopontine angle, which is where all of these are coming out, the 6th, 7th, and 8th. Much more, if you have a subarachnoid lesion that is affecting the 6th, it's much more likely to affect the 7th and the 8th and give you a complicated cranial nerve palsy. If you have a subarachnoid lesion affecting the 6th, also much more likely to get some type of cerebellar signs in terms of balance or nystagmus type of signs, just because of the closeness and proximity of everything coming out at the same time. So your subarachnoid 6 is going to be very vulnerable to things like inflammation, a neoplasm, any type of severe head trauma, or any type of infection in the brain, or any type of increase in the intracranial pressure. So this one more so than the rest of them in terms of vulnerability to increased intracranial pressure is because, let me see if I have a better picture. Yep, is because your 6th nerve is going to exit here and it's going to go over the clivus over here, right? It's going to pretty much have a direct straight shot over the clivus. So when you have an increase in your intracranial pressure, then your brain stem right here, because of all of the increased weight, can actually herniate down or get pushed down into this huge hole right here, the foramen magnum, right? So because things are kind of weighted down, the brain is heavier than it usually is because of all the extra fluid floating around in there. The brainstem kind of moves downwards in the foramen magnum, and that is going to pull and stretch that 6th cranial nerve over the clivus, which is this flat bone right over here, giving you or potentially causing a bilateral 6th cranial nerve palsy during an increase in intracranial pressure episode. So if you ever have a bilateral 6th palsy where neither eye is able to abduct, then we're really, really concerned about an increase in intracranial pressure in those patients. So in terms of our differentials, one of the bigger ones that can be confused with the 6th nerve is going to be Duane syndrome. There are different variabilities and versions of Duane syndrome, but one of the main ones is going to be Duane's type 2, I believe. What is going to happen is you have a congenital disorder where you have an agenesis or poorly developed or poor development of either the abducens nucleus or the abducens nerve. So because it's congenital, the patient's going to be asymptomatic. And when they do try to abduct, what's going to happen is the globe itself, so the eyeball, is going to actually retract back into the globe. So you're going to have a closure of your aperture because your globe is retracting back. And so you're going to have a narrowing of your palpebral aperture. When you're gonna do force duction testing on these patients, because you've been having an overaction of your medial rectus, because the lateral rectus hasn't really been involved, and so your medial rectus is going to get a little bit hypertrophied as a consequence. If you try to do positive force duction testing, it'll be positive in these patients. So you're going to have an asymptomatic patient because it's congenital, so you're not going to have an acute onset. You're going to have a restriction of abduction, and then when the patient actually tries to adduct, everything is going to go in and move in, and you're going to have a narrowing of the palpebral aperture. Okay. So we can see, we can see here the patient is not able to look over to the left with their left eye, but then when they look over to the right, everything's kind of retracting back and their palpebral fissure is getting smaller. One of the other differentials is going to be orbital trauma, right? So anything local. So if we have any type of fracture to the medial orbital wall, that's going to entrap the medial rectus muscle, and you're going to have positive force ductions. The patient is not going to be able to abduct, but here you're going to have an obvious history of trauma to the orbital area. One of the other ones, this is actually a lot rarer than people might think, is a spasm of the near reflex. Having an actual real spasm of the near reflex is pretty uncommon, but this is a convergent spasm where you present with a bilateral abduction deficit, right? So it can mimic increase in intracranial pressure with the 6 nerves being stretched over the clivus, giving you a bilateral 6. But here you're going to have a constricted pupil because you have a spasm of the near reflex. Remember, the near reflex is going to cause you to converge. It's going to cause you to accommodate, and it's going to cause you to have a constricted pupil. So because you're converged, you're not able to diverge or abduct. And because you are very over accommodating, you're going to have vision blur, usually especially far away, and you are going to have very constricted pupils that don't dilate. Right, so that's going to be your spasm of the near reflex. Your patients are going to complain of intermittent diplopia with vision blur, a lot of times a lot of asthenopia and frontal headaches as well because you're over accommodating so much. But once you cycloplege these patients and you release that spasm through cycloplegia, the diplopia goes away, the headache goes away, they feel much better. And that kind of the treatment in sense is going to give you the diagnosis. So in our older patients that have a known arthrosclerotic disease, right? We have an acute 6 nerve palsy in an older patient where we know that they have uncontrolled hypertension, diabetes, whatever it might be. We're going to co-manage with primary care, possibly neurology, but usually with primary care of the actual arthrosclerotic ischemic factors, and we're going to observe them, take a look, and maybe give them a patch or do a partial occlusion on the lateral side of their glasses so that they don't have diplopia when they try to look over to the side. We are going to do a DFE for all of your cranial nerves. You're going to take a look whether it's dilated or undilated before sending them off at the optic nerve, because you want to make sure that there's nothing going on with the nerves, such as papilledema from increased intracranial pressure, but especially with your 6 nerves, because an increase in intracranial pressure can very likely produce a sixth nerve palsy, you want to make sure that you're looking at that optic nerve head to make sure there's no papilledema or swelling of the optic nerve from increased intracranial pressure. If you take a look at the patient, you say, okay, this is atherosclerotic, it'll resolve in about 3 months. We just need to control your diabetes a bit better. And then things don't get better after 3 months, or the condition progresses, or you get any type of additional neurologic signs or symptoms, that's when we're going to start doing more of a neurological evaluation and possibly ordering image studies. If we have an acute sixth nerve, it's a young patient, and there is no known trauma and no known middle ear infection. So middle ear infection, because that can spread over to the pathway of the sixth nerve. So if there's a middle ear infection, especially a severe middle ear infection, it can actually cause a temporary sixth nerve palsy. So young patient, no middle ear infection, no recent history of trauma, or an older patient where there is no arthrosclerotic disease of known to you or the patient, that's when this becomes not necessarily an emergency, but an urgency, where you want this patient evaluated within the next week or so. So emergency is they head off to the hospital, or they need to be seen, tomorrow. An urgency is more so within the next week, possibly two, depending on your location. So this is where you send them off to neurology, and they get a CT or an MRI. If vasculitis is suspected for your older patients, 65 and over, then we're going to do an ESR for GCA. We're also going to look for inflammatory factors. So we're going to run an ANA as well as a rheumatoid factor with their blood work. Again, don't forget your DFE to look for that optic nerve head swelling, especially on your younger patients. Differentials are going to be things like Duane's, congenital esotropia, thyroid eye disease is a given for all of them. Lateral rectus meiosis, or entrapment of the medial rectus if there was a history of a trauma. So that is our third, our fourth, and our sixth. So we are going to move on to our seventh, right? This picture right here gives a nice little overview of our third nerve, our fourth nerve, and our sixth nerve. All of them go through the cavernous sinus, go through the superior orbital fissure to then go on and innervate the muscles, the EOMs of the controller eye movement. So we are now going to move over to our facial nerve. The facial nerve is kind of an outlier from what we've been discussing, but it's all on the face and around the eye. So I figured I'd put it in here. The facial nerve is unique from the other cranial nerves we've been talking about because it has both a motor as well as a sensory component. So all of our other cranial nerves that we discussed only had motor components. So for our seventh nerve, our motor component is control of muscles of facial expression. It also controls our nasal glands, lacrimal glands, and salivary glands. But it also has a sensory component as well, and that's going to be taste to the anterior 2/3 of your tongue. And then there's also going to be preganglionic parasympathetic fibers that are going to go to several of the head and the neck ganglia. So it has a lot of roles to play, both in terms of the motor as well as the sensory components of our face. The anatomy and neuroanatomy is going to be extremely, extremely important when we talk about our facial nerve, because there's going to be different innervation to the top part of the face and the bottom part of the face. And depending on how the patient presents in terms of the type of palsy they have, whether it's the full up and bottom part of the face or only the bottom part of the face, that is going to indicate to you how much of a critical emergency or urgency this is going to be. So let's go through the anatomy a little bit closely so that we can understand that all. So the motor part of the seventh nerve is going to be controlling your muscles of facial expression, right? So for your upper face, which is kind of your cheekbone and up, your upper face is going to get innervation from both the right and the left side, so both ipsilateral and contralateral. And your seventh nerve is going to control raising the eyebrows, closing your eyes, as well as frowning and raising your cheeks up when you smile, right? Like that. So when you kind of smile enough to twinkle your eyes. So it raises your eyebrows, it closes your eyes, it allows you to frown, and it raises up your cheeks. So that's the upper muscles of facial expression, innervated both by the right side and the left side. Bilateral, ipsilateral, contralateral innervation. Your lower face, so that's your ability to close your mouth, to smile, as well as to either suck or to whistle. That is only going to be controlled by one side, and it's going to be the opposite side. So your right lip is going to be controlled by your left brain. Okay, upper is bilateral, both right and left, so ipsilateral, contralateral. Lower is only the contralateral side. Okay, it does not have bilateral integration or innervation. So let's go through this a little bit more. If we are taking a look at the right upper face, that is going to get innervation both from your left side as well as from your right side, right? So if your left side stops working, then your right side will still innervate the upper part of your right face. The lower side is only going to be innervated by your contralateral brain. So if we follow the track over, it's only the contralateral side. So if we have damage to the ipsilateral side, it's not going to affect the bottom part of your mouth. But if we have damage to the contralateral side, it's going to definitely affect the bottom part, but not the top part. So the top part is still going to be intact and functional, but the bottom part is not. Okay? All right. So we said all that. I think we all understand that. So if we have, so now this is where the important part is. If we have a lesion in the cortex, right? So in the brain, inside of the brain, the contralateral part of the lower face is going to be involved, but not the upper face, right? So if you have a lesion in the cortex, so if it's a seventh nerve palsy that's stemming from the cortex, there's a problem in the cortex itself, then you are going to have a contralateral palsy of your lower face, but your upper face is going to be fine because that has bilateral innervation. If the palsy is to the nerve itself, right? So it's not in the cortex, but it's subarachnoid or to the nerve as it's going through the pathway to get to the different portions of the face. If the lesion is to the nerve itself, not in the cortex, but to the nerve itself, that's when you're going to have both the upper and the lower part of the face affected. Okay, so again, lesion to the actual brain itself, your contralateral lower face is going to be affected. You're not going to be able to smile or whistle on the contralateral side, but your upper face is going to be fine. You're still going to be able to raise your eyebrows and to frown. Okay, that's a cortex lesion. That's bad. I mean, they're both bad, but that's worse. Palsy to the nerve itself, so it's out of the cortex, it's making its way through the subarachnoid space to get to the face. that's when you have an ipsilateral full face hemiparesis, right? So still bad, but not as bad as having a cortical lesion. So let's take a look at it in pictures. The whole entire face, then it's a problem with the nerve itself, right? So the nerve itself, once it has left the brain stem, is the problem. And so you have an ipsilateral upper and lower facial palsy. If it's a problem in the actual cortex, then contralaterally only the lower part of the face is going to be affected. So you're going to have that lid droop, but you're not going to have any issues with your upper. All right. I'm repeating this because a lot of people have a hard time kind of conceptualizing or visualizing. So hopefully that makes sense. You guys are welcome to go through the slides and look over it again, because it is a neurologically much more complicated kind of process and idea. Either or, right? If you have palsy, then we are going to be much more worried about, and we're going to be calling 911 right away. This is an emergency, kind of no matter where things are, but much more significantly, much more kind of scary or indicative of an emergency or a stroke if only the lower part of the face is involved, right? Because that's indicating that it is a cortical lesion. So we're worried about ischemia, about a stroke, about a tumor, any type of trauma to the area or to the nerve, or multiple sclerosis can also mimic this type of a lesion. All right. So if we have a brain lesion, if we have a lesion to the seventh nerve of the nerve itself, right? It's a peripheral lesion. It's not a cortical lesion. And we have known risk factors, right? So we have the ipsilateral upper and lower face involved. We have known risk factors such as a trauma, such as herpes, Lyme, things like simplex or zoster can cause issues with your seventh nerve. Things like diabetes or sarcoid can also cause problems with your seventh nerve. If it's an ipsilateral upper and lower, we know it's a peripheral lesion, and we know that they just recently had a middle ear infection that was really bad. They recently had have been diagnosed with Lyme. They have sarcoid that is not well treated or managed. They just had a bout of herpes. They just had a bout of zoster. Then that's an urgency. Okay, so within the next week or so, we want to get blood work. We want to get a CT. It's not a cortical lesion. If you have a upper and lower ipsilateral lesion, but there are no other known factors, right? So there hasn't been a recent cold, there hasn't been a recent herpes, there's no diabetes or anything like that, no middle ear infections, then that is going to be an emergency. We need to figure out what exactly is going on a much faster level. And so that's when they get sent over to the hospital right away. So we're talking today or tomorrow as opposed to within a week's worth of time. Bell's palsy, a lot of people will kind of confuse Bell's palsy with facial nerve palsy. Bell's palsy is a specific nomenclature of a type of seventh nerve palsy. Bell's palsy is a diagnosis of exclusion. So you've checked for everything, you've gone through everything, and there is no cause for the seventh nerve palsy. That's when you call it a Bell's palsy. If there's a cause for it, so it was caused by diabetes, for example, you call it seventh nerve palsy due to diabetes. You don't call it a Bell's palsy. Bell's palsy in its nomenclature means that it is idiopathic. We don't know what happened, why it happened. There was no cause for it. There's an idiopathic facial nerve swelling. It could have been immune, it could have been viral. We don't know the cause of it, but whatever happened caused swelling of the seventh nerve. It got compressed as it passes through the facial canal. So the seventh nerve, as it goes through the cortex to the brainstem, it passes through this little tiny facial canal right over here, which is very, very tiny. Very there's not a lot of room there for the facial nerve to pass through. So if there is any type of swelling, edema during a middle ear infection or during any other type of sickness or inflammation, then the seventh nerve is going to get kind of nicked a little bit. There's going to be inflammation, there's going to be ischemia, and you're going to get a temporary paresis of your seventh nerve. One of the main reasons for this to happen is herpes simplex, followed by herpes zoster in terms of the more common causes. A lot of times the patients are going to get pain behind the ear before they actually get the seventh nerve. So if you have a patient coming in saying that they, recently had a seventh nerve palsy, they're trying to figure out what's going on, why it happened. A lot of times, especially if it's a viral cause, they're going to get this kind of pain or discomfort behind the ear before the palsy actually takes effect. Things that go along with a seventh nerve palsy that are going to be your red flags, that are going to be your emergency to send, call 911 and send them over to the hospital is, again, only the lower part of the face involved. If there's any pain, if there's any other neurological signs like problems with balance, if they have numbness to their limbs, if they have slurring of their speech, then those are all, a 911 call. If this has happened before, so this isn't the first time that this is happening, any involvement of any of the other cranial nerves, or if this has been going on, so it's not necessarily 911 for this, but if this is something that's been going on for 6 months, hasn't been getting any better whatsoever, that's also something that needs to be evaluated, reevaluated. In terms of our differentials, there's a very large variety, anything from, botulism to autoimmune disorders to sarcoma or meningitis. So there's a lot of things that can cause or mimic or worsen a seventh nerve palsy. Okay, so that's it for our specifics. We're going to just do kind of like an overview of how to approach our nerve palsies, and then we'll have about 10 minutes or so for our Q&A. So people get very bogged down on etiologies, like why did this happen? What was the cause of it? A lot of times you're not really going to figure out the actual cause with these things. So a lot of times you're going to be left wondering, or it's not going to be a clear-cut cause and effect type of situation. So just take things a little bit more laxly in terms of why it happened, and use your etiologies a little bit more so as a guideline. So when we're trying to figure out the most likely etiology for a patient, you need to consider both your current as well as your past medical history for the patient, what their signs are, what their symptoms are, and very important to figure out if the palsy is isolated, meaning it's just that one palsy, or if it's complicated, meaning there's other cranial nerves involved, or there's other neurological signs like headaches, nausea, dizziness, loss of balance, that can be involved, right? Because that's going to kind of gauge where the lesion might be, as well as how acutely you need to address it. Anytime you have a new onset palsy, you're going to consider it as either an urgency or an emergency, right? So no new onset palsy is going to just be like, oh, I'll see you back in 3 months and we'll see how things are going. New onset palsy, urgency or emergency. It's a matter of how quickly you're going to get them evaluated. Your red flags are going to be, again, a complicated sign, meaning more than one cranial nerve involved, an atypical presentation in terms of their age, their history, meaning they don't have any atherosclerotic risk factors or any other type of neurological signs. So all of those are your red flags, pushing it much more towards an emergency that needs to get evaluated right then and there. When we're talking about nerve palsies, one of the most important things to consider when managing an acute onset is to try to identify the cause as quickly and efficiently as possible. So we're going to classify things or ask the following questions. Has there been a recent trauma, right? So usually if the patient comes in and they have a palsy, but they had a recent trauma to the face, or they just fell off of their bike, or they had a recent car accident, whatever it might be, we are much more likely to be considering this cranial nerve palsy to be traumatic versus not. If someone has an acute presentation of a palsy and there's no history of trauma whatsoever, we're much more concerned about other neurological causes than if they present with a recent history of trauma. If there is no history of trauma, we then want to see, is it neurologically isolated, or are there other neurological signs or symptoms? So if it's neurologically isolated, that doesn't mean that it's not an emergency, but anything that is not neurologically isolated, meaning you have any other neurological signs, that's an automatic emergency room visit, no matter what's going on, right? So that's a true emergency right then and there. In terms of history of diplopia, we want to know when it started. Is it getting any worse? Are there any other signs or symptoms along with the diplopia? A lot of times people will come in complaining of diplopia, but it's actually just a haze. So the way I like to ask my patients if they have diplopia is, when you're looking and you think you see double, is it two separate distinct images, or is it just a little bit of an overshadow with a little bit of a haze, where they're together, but it's a little bit more hazy? And a lot of times, if it's due to uncorrected refractive error, especially uncorrected astigmatism, sometimes from cataracts, it'll be more of a haze, as opposed to, is it, and you want to kind of show your hands, is it two separate distinct images, one from the right eye and one from the left eye? And that allows your patients to really tell you if they actually see diplopia or not. Monocular diplopia is not going to be neurological. It's going to come from the uncorrected refractive error, from your cornea, from your lens, from your macula. It's not going to be neurological. You also want to find out if it's horizontal, diagonal, vertical, because that's going to pinpoint possibly which extraocular muscle is involved, right? So if it's diagonal, it's much more likely to be a fourth nerve. Vertical, horizontal, is it worse on right gaze? Is it worse on left gaze? Up gaze, down gaze? Is it worse at near? Is it worse at distant? So all of those are going to help you figure out which EOM you're going to be concentrating on. The other thing, especially for new onset diplopia, is comitancy. So comitancy means, is the strabismus or the diplopia worse in any particular gaze? So a lot of times people will ask, well, how do you know that it's not just a strabismus, right? How do you know that it's not just a decompensated phoria and it's a strabismus? So a strabismic diplopia is not going to be incomitant. It's always going to be comitant, meaning you have, let's say, 15 prism diopters, exotropia in primary gaze. It's still going to be 15 in right gaze, still going to be 15 in left gaze, still going to be 15 in up and to the right and down and to the left. It's going to be 15 prism diopters, right? Because there's no restriction. It's strabismic. You're going to have a comitant deviation. Something that is neurologic, or something is restricting EOM movement, that is going to give you a non-comitant deviation. So if you have a diplopia that's non-comitant, that's a very, very big red flag, especially if it's new onset or worsening or progressing. The modified Thornton, again, a lot of times cover tests, it could be hard to tell, right? Because it could be maybe 5 or 6 prism diopter difference, and that could be hard to pick up on if you're not, doing cover tests all day, every day. So the modified Thornton, where you have that chart, that grid with the light in the back and the red lens held over one of the eyes, where one eye sees the light and the other eye sees the light, the red line, and the patient can tell you if the light and the line are getting further apart or closer together. That's a much easier way to try to figure out if the deviation is comitant or not. you're going to be part of the triage team, the primary care team, right? So a lot of times these patients can come to you with a very significant problem, like they have an impending or an active stroke, or they have an aneurysm that's about to burst, or they have Lyme disease that is causing a palsy, right? So a lot of times you are going to be the person that is going to be picking up on these systemic things that can either be potentially life-threatening or, if not treated properly, cause lifelong issues. So it really is important for us to make sure that we are evaluating our patients and doing the proper handoff, evaluation, workup, and sending them off in the proper kind of time frame for these types of conditions. So unless it's a known entity, it's longstanding, it's stable, it's an already worked up condition, if you get a palsy in your chair, an acute onset palsy, it's going to be co-managed with somebody else. It just kind of depends on how urgently that co-management is going to happen. And again, like we mentioned, it's very nice to have a good relationship with a neuro-ophthalmologist in these types of cases, because they are going to know what to do, how urgently to do it, how to do it much faster. If you don't have a neuro-ophthalmologist, then a neurologist, and then that's going to be followed by a primary care provider in terms of your steps of who to talk to in these types of situations. Okay, I do have some more slides, but I think we'll probably stop there and take questions. I don't actually know how many questions we have, but here's my email. If anybody has any questions that you want to discuss off chat or off Zoom, I'm going to turn this off and stop sharing so I can actually see you guys. Hi. I feel like I've been talking to myself these past 2 hours.
I promise we've all been here. I know when you can't see, you're like, am I still
Yeah.
talking to everybody? Is everybody there? So
Yep. There's
we
also a huge window right here, and there's been a pigeon that's been trying to like bash its way into the window for some reason. So it's been an interesting 2 hours.
Well, thank you for that. Do you have more slides? I mean, we have plenty of time if you want to keep going with your
Well,
slides.
there was, let me see what I had left for you guys. It was more of like a case, like case examples and showing things like pictures. Do we want to do that for like
I
another
think
5 minutes?
we've
Okay,
got plenty
so
of
then
time, so why don't we keep going with that? And
let's
then just a
go
reminder, keep those
back in.
questions coming.
All right, so let's go back in. All right, so a lot of times people have a difficulty kind of identifying or figuring out if it's when you have a third nerve palsy and it's not a complete, so it's an incomplete third nerve palsy. They kind of are very unsure to say, well, is it a third nerve? Is it not a third nerve? Because it's not fully complete, so the patient can still adduct a little bit, and what's going on. So if it looks like a third nerve, but some of the EOMs are still functional, what you're going to look for is that reversing hypertropia that we talked about. So that is going to be your key to identifying a third nerve when it's not fully formed, it's not complete, it's still developing. So you're going to be looking for that reversing hypertropia. Again, remember, so for example, here we have an incomplete third of the left eye, right? So he looks pretty okay. He's got ptosis, but it's not horrible, right? Not what you would expect with a levator problem. He is able to adduct his left eye still, right? So his medial rectus is still functional. He is all good over here when he is abducting, so no issues there aside from being able to elevate over here. But when you just do the direct superior and inferior, you're going to get that reversing hypertropia. So remember, because you have an effect on your elevators, when you are looking up, then your contralateral eye is going to be hyper. And when you're looking down, because your depressors are also not functional, your ipsilateral eye is going to be hyper. And again, like I've said several times, doing a cover test or observing these patients, especially in the more mild cases when things are developing, might be difficult. So doing that modified Thornton. So if you're holding the rod this way, then the line will be horizontal, and so you can tell them, is it higher, is it lower, and that way, instead of doing a cover test, you can just have them objectively tell you, where the line is sitting relative to the light, to see if there is a switch in the hyperopia, or which eye is hypertropic when they're looking up versus when they're looking down. So if there's a flip of, in when they're looking up, the light is in the middle and the line is higher, but then when they're looking down, the light is in the middle and the line is lower, that's your reversing hypertropia, much more indicative of a developing third nerve palsy. So that's what that looks like, an incomplete third nerve. And if you have an incomplete third nerve, you are going to assume that it is an aneurysm in progress, and that is going to be your emergency to call 911. Anything that is an incomplete, whether the pupil is involved or not involved, that is a 911 over to the emergency room. Let's see here. Okay, so this is for the aberrant regeneration for if we have a third nerve that is not ischemic. Again, remember, ischemic does not cause third nerve palsy. Ischemic third nerve palsy doesn't cause aberrant regeneration. So if you're having aberrant regeneration, then we're going to rethink the diagnosis of ischemic, right? There's something else going on. It could be a tumor, it could be an aneurysm, it could be a traumatic, but it's not ischemic. So with your aberrant regeneration, so say you had an aneurysm and then the aneurysm got clipped, for example, right? And now you have a misdirection or an aberrant regrowth or regeneration of some of those third nerve fibers. What is going to happen is when you have the patient look down or adduct, they are actually going to have a ptosis of their lid. No, I'm sorry. A retraction. So when they're looking down or when they're adducting, they're going to get a retraction of their lid, and they're also going to get a constriction of their pupil. Okay, so that's what the aberrant regeneration looks like. For our superior oblique palsies, again, make sure that you take a look at their pediatric pictures or their pictures from, say, a decade ago, because a lot of times they'll have a tiny little head tilt that they never picked up on, or their parents or anyone around them never picked up on. But you have a baby right here that has, so just in your mind, right? Given the tilt of the head, what do you think? What kind of is it a right or a left superior oblique? So remember, they're going to have a habitual tilt to the contralateral side. So if they're tilting over to the left side, then it's their right eye that likely has a superior oblique. So you can see the baby has it, she's probably like 6-9 months, and then she still has that little head tilt over to the left side, probably 4 or 5 years old. And then with our superior oblique palsies, this is one of the only ones where a sudden onset of diplopia doesn't necessarily mean an acute onset of the actual dysfunction, because we can have a superior oblique palsy or a weak superior oblique that the patient has been able to make up for and fuse for without diplopia with a robust binocular system. But now they're getting older, they're very tired, they're stressed, they've been sick, there's inflammation going on. Their system is no longer able to use those fusional reserves to fuse the two diagonal images, and things decompensate. And now all of a sudden they have sudden onset symptoms of diagonal diplopia, but that actual palsy, the superior oblique palsy, has been there for a long period of time. So this is kind of one of the only times where a sudden onset diplopia doesn't necessarily mean a sudden onset palsy. Okay. And the way that you would differentiate that is, one, to look for the head tilt that's been there for decades, but two, much more importantly, to look for that extended vertical range, so about 6 prism diopters or larger. Okay, a patient presenting with new onset esotropia, horizontal diplopia, can be differentiated between, so we can differentiate between cranial nerve 6 palsy and a decompensated phoria that now becomes a strabismus by what clinical sign, right? So you have someone coming in with an esotropia. They have horizontal diplopia. What is one of the ways that you're going to differentiate a decompensated phoria? So it was a large phoria. They used to be able to fuse things because of a robust binocular system. But again, now they're older, they're sick, whatever it might be. They're now broken down into a strabismus, an esostrabismus, esotropia. How are you going to differentiate that from an 6-nerve palsy? What is one of the clinical signs or things that you're going to look for? I'll give you a second just to think about it in your head. So that's going to be your comitancy, right? So remember, strabismus, right? A strabismus is not going to give you an incomitant sorry, my brain's not working anymore. It's not going to give you an incomitant number, right? So if they were 20 ESO looking straight ahead, there's still going to be 20 ESO to the right. There's still going to be 20 ESO to the left if it's a strabismus, right? So say it's an non-common, if it's a decompensated phoria that now turned into a strabismus, right? But if it is a palsy, then they are going to then be non-comitant, meaning the amount of deviation is going to be worse. And when we say non-comitant, we're talking about greater than about a 4 to 5 prism diopter difference between straight ahead, to the right, to the left, up, down, all your 9 cardinal positions of gaze. So about 4 or 5 prism diopter difference or more. That's when you go into the realm of being non-comitant. That's when you start looking at either a palsy or a restriction to the actual movement of the muscle itself. Okay, and this is an esotropia where things are comitant. So no matter if they look to the right, to the left, no matter where they're looking, it's going to be the same amount of esotropia, no matter what the gaze. What signs and testing can help differentiate a cranial nerve 6 palsy from Duane syndrome? So cranial nerve 6 palsy, where we have a difficulty abducting the eye, versus Duane syndrome, which is a congenital dysfunction. So what are the things you're going to be looking for in terms of the movement, the eyelids, the eyeball, to differentiate those two, aside from, they've had this for their whole entire life? So one with a Duane's, so Duane's type 1, which is the more common one, and the one that is going, it wasn't type 2, I'm sorry, it was type 1. That is going to be confused for a 6 nerve. So one, the patient's asymptomatic because it's congenital. Two, there's going to be a positive force duction. So when you either with a Q-tip or with forceps try to move things over, there's going to be resistance because that medial rectus muscle is very, very taut and kind of thickened and not easily movable. And then when the patient adducts, so when they converge or adduct, you're going to get narrowing of the palpebral aperture and a retraction of the globe back into the socket. Okay, so those are the things that are going to differentiate your Duane's from your 6 nerve palsy. Okay, so where am I going? I'm here. All right. So we can, we have questions. Yes.
We do have questions.
Okay.
So let's see.
Let's
All
go.
right. First of all, thank you. That was amazing. And
Yeah.
the cases really helped, I think, kind of drive all the messages home. So I'm glad we had time for
Yeah,
those.
I'm glad we had time for that. Yeah.
Let me get into the Q&A. Let's see. Okay, so could you please review the difference between incomplete and complete third nerve palsy?
Okay. Do we still, because I think the case we just did that. Do we still want to
Okay.
do that? Because
I,
so with just really quickly. So with the incomplete, you first of all will likely not have pupillary involvement. The ptosis might not be as severe as you will with a complete. So with a complete, you're pretty much going to have no function of your levator. So you're going to have pretty much a fully closed lid, ptotic lid, whereas with an incomplete, it could be halfway closed. With a incomplete, when they're looking straight ahead, the eye in primary gaze might not be fully down and out. So with a complete, you're going to really get that down and out eye with a full ptosis, where with an incomplete, you're not. And some of the EOMs, like for example, the medial rectus, might still be functional. And so what you're going to really be looking for is going to be that reversing hypertropia.
Perfect. There were a couple questions actually for people who are practicing in rural areas where
Yeah.
resources are limited
Yeah.
and they might not have all of the resources that you mentioned. How would you suggest they work with these patients?
Yeah, I mean that's a hard one because it's always, like an acute palsy comes in, you're going to be worried. But I think you need to kind of gauge your worry level to what else is going on, right? So really take the whole entire patient into account. So if it is a patient, again, anything complicated, anything like cranial nerve palsy plus. So another palsy on top of it, any other neurological symptoms. The history doesn't make sense. They don't have other atherosclerotic risk factors that have been uncontrolled and, their A1C is like a 27 or, you know what I mean? Like anything that doesn't make sense, that is going to be your red flag. That is going to be, hey, we're going to send you off right now. All the other ones in terms of it's they have known risk factors. There's no other neurological signs and symptoms. And things have, because usually people, even though like it is an emergency, a lot of times people will show up like 5 days later, even though they should have been in your office that same day, right? Um, hey doc, I got this sudden onset diplopia, 5 days ago, but I've been at the beach because I needed a break, kind of a situation. And things have kind of been stable. And it's an older patient with a known atherosclerotic risk factor that's out of control. They're not taking their meds. And there's no other neurological signs. That's when it's a little bit more okay to just kind of work with their primary care as opposed to sending them off right away. Everything else in the middle is kind of you kind of gotta work within your comfort level and whatever resources you have, and there's no textbook right answer, which I hate that response because I like everything to be textbook right answer, but unfortunately that's not the world that this topic lives in.
Perfect. There was a comment that somebody just wrote that I liked. That was fabulous. They feel ready to take the national boards again. So,
Oh wow.
so that's a huge compliment. So I think I just thought that was
Thank you.
wonderful. Another question is that there's often talk of partial third palsies. Can there be partial sixth or fourth?
Partial sixth or fourth. I'm gonna say no because the reason we have partial thirds is because you have the two different bifurcations of the upper and the lower part. So you have the third nerve going through, but then once it passes the superior orbital fissure, then it goes to the superior and inferior components. And so that's why you have that incomplete component. But with your fourth and your sixth, it's kind of just one nerve that controls everything. And so what you can get in these cases, not as bad of a palsy as opposed to like a full complete one if something is in the developing stages, in the earlier stages. So it might not be like a complete palsy, but it's not going to be complete is, I guess, the wrong word. It's not going to be like a full-blown palsy. So it might be a weakness to the movement, but you're not going to have an incomplete palsy in terms of what we have in the third nerve, where some things are still functional and some things are not still functional because of that bifurcation of the superior and inferior branch. That's a really good question. I've never had that question before. So I'll be honest with you, I just kind of made that whole answer up. So if there's anyone on here that's smarter than me, please chime in, because I just kind of just talk that out. Yeah.
That's a fun part of Q&A. Sometimes they're easy and sometimes they're super challenging.
Yeah.
Here's an easier one. What was the name of the device to measure prism at near, looking at the card with the Maddox rod?
Oh, modified Thorrington. Let
Thank you.
me, do I have it written down somewhere? Modified Thorrington. Thorrington is T-H-O. Hold on, let me Google it. I'm a horrible speller. And then they have it both for distance and for near, so you can get both. Here, let me just type it into the chat. Let's see here. It's a really cool test. So if you do anything, where is the chat? There it is.
Oh.
And that goes to everyone. So the modified Thorrington, in actuality, aside from like this world of neuro, is a wonderful test to do for a lot of your patients going from pediatrics to geriatrics, because it's a very, very quick, easy, simple, easily understood test to allow you to figure out what the phoria is. If it's ESO, exo, hyper, hypo, very quickly and easily. So it's definitely a test that I don't usually recommend, like I don't usually love tests, but this one really is one that is helpful in a very large set of different patient populations.
Let's see. And just a reminder, keep those questions coming. You can still add. What does the management and patient education look like for ischemic third nerve palsy? Is it short-term prisms or what would that be?
So a lot of times the patient would really act. So if they have that severe ptosis, a lot of times they're perfectly fine because they're unilateral anyway, because they're fully ptotic. So you don't even have to do anything. They are not symptomatic until you kind of lift their lid up. So in the beginning stages, before they start to recoup their function, they're perfectly fine just walking around fully ptotic. If there is a aesthetic component, you might want to put a patch on so that people don't see that they're fully ptotic, but symptomatically, they're not going to have symptoms because they're monocular. Once they start regaining function and the ptosis starts to resolve and they start becoming symptomatic, then it kind of depends on the patient. So if they don't mind being monocular or looking aesthetic, walking around with an eye patch, pretty much, you can just patch them, whether it be the patch, the pirate patch they buy, or we have the patches that can kind of stick on and glue on to the eye. If it is not an aesthetically good look for them, then there are several things you can try. So you can try just putting Scotch tape on the glasses, if they wear glasses, of that eye. So not the translucent one, but the one that's kind of frosty. Just tape that lens up so that way it doesn't look like there's something very obviously wrong unless someone is really up close and looking at them, but they are no longer able to see out of that eye, and so they're asymptomatic. And then as things start to resolve and symptoms start to get better and better, then there might just be kind of like little areas where they are diplopic. So maybe like in the inferior portion of their visual field is where they're more diplopic. And so you just put the tape, or you can use clear nail polish, but you kind of stipple it. So you let it dry a little bit and then you kind of like dot it so that it's not just like a smooth nail polish coat, it's kind of stippled, and that will also blur the vision enough where they don't have that diplopia anymore.
Perfect. How do you triage an intermittent temporary diplopia? For example, lasts a few seconds or a minute and then goes away. Typically a decompensating phoria, or are you concerned about anything else with intermittent temporary diplopia?
So in that case, you want a really good history in terms of when it's happening. So is it only happening after they've been reading or they've been on their phone for a long time? Because if it's something that's decompensating, the reason it would be decompensating is because they have visual stress, they have systemic stress, they have, they're physically tired, or something else is going on to make them kind of decompensate. So you want to take a really, really good case history in those types of instances to tell you if there is something visual or stress wise that is bringing those symptoms on. So when is it happening? How frequently is it happening? So if it's kind of a visual stress related or a phoria that's decompensating into a strabismus back and forth, so say you have someone that works at a computer all day long, right? Ask them, if you spent the day on the beach and you're not looking at your computer for the day, do those symptoms still occur or not? So you want to try to take as comprehensive a history as possible to figure out if it's visually stress related or not. If it is visually stress related, then you want to do a really good binocular workup. A lot of times when you have a younger patient who's healthy and generally kind of has a robust binocular system, you might not be able to weed out those signs clinically until you get them. So if you get them coming in at like 9 in the morning, they haven't gone to work yet, they had a good night's sleep, you might not get any signs or symptoms of strabismus whatsoever, but you have them come at the end of the day after they've been working on the computer all day, they've had a bad night's sleep. And then what I'll do a lot of times is I'll redo testing. So say I'm doing cover test or NPC and everything looks okay, then I'll do the rest of my testing with my phorias and my ranges and looking at eye tracking, all of that, and then I'll repeat my NPC and I'll repeat my cover test. And a lot of times that's when you'll find it'll pop up that now they're breaking down into a strabismus, and that's where their symptoms are coming from. So if you do all of that and there's still no kind of visual signs, that's when I'll dive more into, hey, let's take a look and see if there's anything else going on that might be causing this diplopia.
Perfect. And I'm going to do one last question because I know we are running out of time. How prevalent is sixth nerve palsy secondary to COVID infections? If you know the answer.
I don't know in terms of the actual answer, but it is common. Fourth nerve would be more common, again, because it is a little bit more susceptible. So with long-term COVID or with COVID in general, what's happening is a lot of our COVID patients are coming in mimicking concussion or head trauma patients, because what happens with long-term COVID is there's a lot of inflammation in the brain that's there for a long term, and that's causing ischemia, and that's causing swelling of the axons. It's causing something called diffuse axonal injury, meaning that nothing is actually like broken or torn or bleeding, but just in general, the whole entire nervous system is globally kind of inflamed and working slow and suboptimally. And so we will get, especially in patients that have a very previously weak and susceptible binocular system, like they had a previous large phoria, those are the ones that are going to then break down and give you an actual strabismus. Third nerve, really not common. Sixth nerve, not as common, but fourth nerve, not to say common, but more commonly seen. But in terms of the actual number, I can't spit that out for you. But I'm happy to do some research and look it up. Whoever's asking, just email me and I'll do a deep dive and find the answer for you if it's out there.
Would you be able to share your email address in the
Oh, sure.
chat one more
Yes,
time?
yes.
That will be my last question because that came up, but yes, that would be wonderful.
Yep.
Perfect. So thank you. So if anyone looking, she was kind enough to share her email address in the chat. So with that, I want to thank everybody for joining. The QR code is up there, so make sure you scan that. If you don't have the OE Tracker app, you will still get credit, and your CE certificate will be delivered to you by email within 4 weeks. So Thank you, everybody who has been here and joined us for the first day of the Ocular Emergencies Summit, all 4 hours of CE. And we look forward to seeing you tomorrow, starting at 8 a.m. Pacific and 11 a.m. Eastern. We will be back with 2 more wonderful lectures. So with that, thank you, Dr. Petrosian, for being here. Thank you, everybody, for spending your Saturday with us. And I look forward to seeing you tomorrow. Have a great day.
Thank you. Bye.